leaders in Indiana's healthcare industry, thought leaders, and people who are making a difference in healthcare policy. You know, when we think of healthcare, so often we think of the great work of physicians and nurses and other healthcare providers. We think of the extraordinary things that go on in hospitals. We think often, at least many of us do, about the hard work and research and development that goes into the development of new medicines and the development of new medical devices. We think about a system that provides healthcare coverage for insured people and a governmental system for uninsured people. These are the things that we think of, but this all comes under a big umbrella. And that umbrella is the U.S. healthcare system. And there is no more dynamic thing perhaps in the world today than the U.S. healthcare system, undergoing changes that have, in my view, really almost barely begun. If we look at the environment that we're facing coming up, we have recently passed, with much pain, as you all know, the Affordable Care Act in this country, but we don't know whether the Affordable Care Act is actually ever going to be fully implemented because the United States Supreme Court is going to decide on one of its key components within the year. We are going to have a presidential and a congressional election in 2012 in which we very likely, almost certainly, are going to have one of the two major candidates pledged to the repeal of the Affordable Care Act and potentially control of Congress in the hands of the Republican Party, which is almost universally pledged to the repeal of the Affordable Care Act. So to suggest that we have settled much in this area, I think is a bit of wishful thinking. So as we think about what might happen in this arena, where healthcare policy in this country might be going, I think it's important that we go back to first principles and think about what it is that we do agree on, what it is that we can get support around. And I think the Aspen Institute's articulation of what I would call their first principles, and I have to tell you, Fran Marie, I had a long day last night, yesterday. I laid down last night. I was going to read a few pages of a biography, but I got started reading the Aspen Institute principles, and I couldn't stop. So that either says something about the principles or it says something about me. But in any case, this is worth spending time with, and I think we're going to have a chance to spend some time both today and moving forward, thinking about these, what I call first principles, these foundations of what a well-functioning healthcare system in this country could be, because I think we all agree we're not there right now. And even the staunchest supporters of the Affordable Care Act would agree that it is at best a first step toward the kind of system that we need to bring higher quality care to our people at an affordable and sustainable cost. So we have a full day in front of us. I think it's going to be an extraordinary day with great keynote speakers, starting with Sam Nussbaum, and a number of panel discussions that I know you're going to find interesting. So Fran Marie, thank you for your leadership. Thank you for coming to Indianapolis and giving us this opportunity, and I'm going to turn the podium back to you.
Well, I think it was all about the principles part. They're riveting. Has nothing to do with you. I am Fran Marie Kennedy, Aspen Institute, and I'm here to tell you why you're here, how you got here, and why it's so important. First, I have to tell you a little bit about the Aspen Institute. Then I'm going to talk to you about the Stewardship Project. And then I'm going to talk to you about the rationale behind the voices. And then I'm going to give you a preview of coming attractions, because we have a lot in store for us. So, Aspen Institute, 61-year-old, nonpartisan, bipartisan, tripartisan, just not partisan organization that is really dedicated to fostering values-based leadership. I prefer to refer to the Aspen model as the honest broker of ideas, because the convenings that the Aspen is so famous for is, values-based, and it's in a neutral environment, and it's all balanced. So every critical issue will be examined from every point of view in a very, very non-confrontational but exciting way. So this takes us to the Aspen Health Stewardship Project. In 2007, the Aspen Institute decided to launch this project so that we could infuse civil discourse into the health reform dialogue, debate, whatever you'd like to call it at that point, knowing that in 2008, this was going to be front and center in the election conversation, and it was, of course. So we convened a bipartisan, that's that word again, panel, and they decided that in this space, the Aspen Institute, did I do something wrong? Sam, is this your?
Oh, no, I think that's our screensaver that gets pushed to our computers.
I did something wrong.
No, you didn't. But this is about our
I'm not.
associate giving campaign.
And so, let me say,
I can get that off.
I love that photo.
I'm so embarrassed.
I did it.
That's what I can do.
I'll just talk over.
Could you put up a Cialis ad for us?
Oh, I'm just
There
going
we
to
go.
do a commercial break. Brought to you by. This is why I love Indianapolis. So where was I? Okay, health stewardship, of course. So the bipartisan panel decided that what they could do best in this space was to put together the first principles on which all sustainable health reform will be and should be based. And that's what they did. We then wrote a white paper, which will keep you up reading excitedly, and it's available online, so download today. The principles are actually in your handout. And then we started building like-minded organizations as a coalition to help us really, really infuse the principles into the discussions about health reform. We felt that it was important to do because we had to get away from the dialogue that was, it's around who's going to pay for the reform and who's responsible. And we really wanted to base it on what are the problems fundamentally and how do we address those. So we did that, and we were all of our partners, all 31 organizations, and all of our partners are actually, a lot of them in the room, all were very gratified to see that the principles really were front and center in the Affordable Care Act. Having said that, just as Bart said, this is just the beginning. We all knew that, and we said, this is a great start, but we really need to keep the dialogue going on what really does work. And thus, we have Voices from Main Street, because we think this is a pivotal time in this dialogue, as Bart pointed out, and it's important to actually start looking at the local solutions for our national problems. And this is the very first of our regional events that will do just that. And so we are videotaping this for the rest of the different regionals. We feel that going across the country in a regional setting like this, focusing on what's working, sharing that, and disseminating those models that work are really the next step in this very important movement to really change forever our health care system. So that's what we are doing. We're going to take this into, again, another election year, 2012. We're expecting to have this series of regionals and then have a Washington event where we will have another bipartisan offering of suggestions for sustainable improvements, and we will present that in Washington, D.C. Now, a preview of really exciting things to come. We are also involved in a very exciting project. Part of the stewardship project is the Health Innovation Project, which we launched this year with our dear partners, WellPoint. And the fact is that it's going to be yet another white paper that will keep you up at night. We're launching that in January 2012 and a Washington, D.C. event. And it is focused on clinical innovations and opportunities for cost containment. And we are really looking at the issue of why the American healthcare system could be so breathtakingly innovative in the medical procedures and treatments, and yet not nearly as well innovative in the clinical delivery. So stay tuned. You'll all be invited to Washington. We will try our best with our weather. And I want to now turn my attentions to my real job that's supposed to be introducing our keynote speaker. Now, the other thing I'd like to say is I cannot thank you enough. I am so grateful that you could be here today, because when I read what he's responsible for, I am awestruck that you would be honoring us with your presence at this event. And I really think that your conversation is really important to our moving forward with this regional event. So Dr. Sam Nussbaum is the Executive Vice President, Clinical Health Policy and Chief Medical Officer for WellPoint. He's also their key spokesperson and policy advocate. In addition, he oversees corporate medical and pharmaceutical policy. Dr. Nussbaum collaborates with key leaders in industry, physicians, hospitals, national policy, and healthcare organizations to shape an agenda for quality, safety, and clinical outcomes to improve patient care for the WellPoint's 34 million medical members. In addition, Dr. Nussbaum partners with WellPoint's Consumer Business Unit to advance WellPoint's international business, and with Healthy Care Solutions, which is focused on improving customers' access to innovative healthcare services. Prior to joining WellPoint, Dr. Nussbaum served as the Executive Vice President, Medical Affairs and Systems Integration of BJC Healthcare. Please join me in welcoming our keynote speaker, Dr. Nussbaum.
Thank you, Fran Marie, for that very gracious introduction. I just walked across the street this morning, though, to get here, so it wasn't much of a journey, and it's so important to be with my community and WellPoint's community. Two themes that you emphasized. One is this is listening from Main Street, and I would argue that Indianapolis's Main Street is really a beacon for what healthcare can be. We heard from Bart Peterson from where Lilly is as a pillar of this community, a pillar in terms of jobs, in terms of making this a community that cares deeply about its people and also bringing solutions and therapies to the world. Also, this is where WellPoint, America's largest health plan, is headquartered. But along with those two organizations are some of the finest hospitals and physician organizations in this country. So it's absolutely a privilege and pleasure to be here. What I'm going to do this morning, though, is talk about innovation. And what is so critical, and my basic theme this morning will be about how we must be innovative in healthcare. Innovation technology is not the enemy. If we use innovation technology wisely, we can improve health, improve healthcare, and make healthcare more affordable. And that's so much of what the Aspen Institute has been about. As you look at, and you're going to hear more about these themes and principles, they are right for our nation. They make absolute sense, and they will allow the competitiveness in a world and market that actually brings new products to market, but also, most importantly, keeps healthcare costs sustainable so that our goods and services are competitive. So that's really what I want to share with you today. And it's really important to recognize, Bart was saying what your night reading was, but one of the other things which we could read is Dickens' A Tale of Two Cities. And if you recall what Tale of Two Cities begins with, it was the best of times and the worst of times. And I think that's actually true in American healthcare today. The best of times because of the extraordinary, unprecedented, breathtaking advances in medical technology and treatments and pharmaceuticals. We have the ability to cure disease, prevent illness, and improve the health of our populations. Yet, the worst of times, the state of public health, the unsustainable healthcare costs. We're up to 50 million uninsured. And the fact that the healthcare services that we deliver are not keeping with the extraordinarily capable science that we're able to create. So that's really where we are today. And these are critical issues in healthcare. While we've focused, and the Affordable Care Act focuses on coverage initially, it's really about access. Even in Massachusetts, where 92% of individuals were insured and had very good health care, as soon as health reform gave greater access to 98% of the population, there were waits to see physicians. Emergency room waits increased. So access is not the same as insurance. The state of public health. We're not going to talk about in great detail, at least I'm not this morning, in terms of what is happening with childhood obesity, which of course represents coming attractions for adult and even childhood diabetes. And we certainly know about the affordability of care and the fact that we have to improve safety and quality. Well, let's look at health expenditures. Let's look at it from the perspective of a nation. We are moving from $2.6 trillion today to, over the next decade, $4.5 trillion. Now, if our economy grows, that will be about 20% of the GDP. If the economy doesn't grow, it could even be more. And then if we look at what's the impact on individual employers and individuals when they begin to purchase health insurance, look at the growth over the last decade. Premiums for the average family from $7,000 to $15,000. And the individual contribution has grown from about $1,700 to $4,000. Health care, if you think of it for an average wage earner in this country, is not affordable. Now, one of the other themes, and this relates to our poor health as well as the cost of care, is that healthcare costs are highly concentrated. This is some Medicare data, and what you can see is that 15% of Medicare beneficiaries account for 75% of spending. So not only do we need to keep people healthy, maintain health so they don't move into this arena of end-stage renal disease and diabetes and cardiac disease, but importantly, when you're there, we need optimal care and optimal care coordination. Now, I want to talk about invention, discovery versus innovation. Some of you may ask why it took so long to get from the wheel to something that seems so logical, which is putting wheels on suitcases. And just think about how this has changed. You know, those of us that spend time in airports, we spend a lot of time sort of wheeling our luggage. But why did it take, decades before that type of innovation was created when there was, in fact, sort of discovery? And I think we're going to have to ask that, because one of the most important issues is how do we take discovery, innovation, and apply it in the right way? We're entering an era of personalized medicine as we understand our human genome, we understand different responses to treatments, to drugs, whom of us will be at risk for developing complications of diabetes or heart disease. So just at this time, when medicine will become personalized and therapies will be less likely to be blockbusters, we have to reconcile how we can make these investments. In addition, I want to comment on drug therapy, because all too often people don't understand the strong value that pharmaceuticals bring. But if you look at the almost 40% reduction in acute cardiac deaths, that correlates not with coronary bypass surgery and not with percutaneous interventions, but with the advent of potent statins. And we can even look beyond that. If you look at deaths from HIV and AIDS, you can see that the death rate is down by about 80%, and that's about HIV medications. And if we look at improved screening and drugs, you can see that cancer mortality in the United States is significantly declining, and more people, the light blue bar, are living healthy lives and living well with cancer. So how do we take then these extraordinary advances in science and make sure that they're applied in the right way? So just think of the paradox. We have surgical robots today that are doing surgery and delicate surgery, and you can see that pictured here, yet we operate on the wrong body part. and surgical checklists, as Atul Gawande has emphasized, can make that different. We talk about payment reform, and I'll share some of that with you in a moment. But payment reform will be related to evidence-based decision-making. If you have payment reform and you're using global payments, you no longer will be just driving revenue through unit cost payment. And of course, understanding genomics and proteomics will allow for specialty drug development, but how should those drugs be used? And we're not talking about just in accord with FDA approvals. Most of us know that for cancer, many of the drugs that we use outside of the FDA approvals. And it's appropriate because there's science that shows these drugs work. So the off-label indications, we have to be sure that we study them. Now, one more comment before we show some themes of innovation and some very specific examples of how we get there, is to really look at what we spend on healthcare innovation. First, if you look at the 6 of the top 10 companies in global R&D, those are biopharmaceutical companies. They're drivers of investment. Over 2/3 of U.S. patents in biopharma were issued to U.S.-based life science companies. And we think of what we want to do in this state in terms of growing BioCrossroads and all those initiatives. This is compelling. And we lead the world in drug discovery. 2/3 of new drugs in the last 10 years have come from the U.S. Currently, 82% of the pipeline is U.S. And it's a public-private partnership that people don't always focus on. But if you look at NIH basic research, that's about $30 billion. And if you look at the private sector, largely biopharma and pharma, $65 billion. And this is Elias Zerhouni's quote, "There's an ecosystem of science and biotechnology, public organizations, private organizations, universities, Congress, FDA. All of this is an ecosystem that's envied by the rest of the world. We can't lose this as in our quest for greater affordability. We must use resources wisely." Now we know, here's a specific example of why we must use them wisely. There are a group of drugs that are called specialty biologics. These are complex protein structures. They represent today about 1/4 of all drug costs, but over the next 4 years, they will represent 40%. So the expenditures are rising at twice the rate of conventional drugs, and the average cost per prescription is $2,000. Annual treatments are between $5,000 and $350,000. So this is a new model on how do we pay for this, how do we finance this. And there are over 600 of these drugs in development. You can see that most are for cancer, but they're for infectious disease and autoimmune disease. So this is about using these drugs with evidence and supporting advancements in clinical knowledge. So what is the architecture for innovation? And what I'd like to speak to is payment innovation, care management innovation, public health, improving health, and consumer innovation in terms of making consumers better partners in their health and their health care and understanding the costs of health care. So let me talk a bit about payment innovation. Some of you may have seen Wall Street Journal covered this, our statement at WellPoint to our hospitals saying that going forward, we are only going to give increases to hospitals if there's an improvement in safety, in quality, in outcomes, and in creating value. Now today, most of us know there's a hidden tax, that the private sector pays hospitals vastly more than the public sector. Organizations like the Center for Studying Health System Change, led by Paul Ginsberg, have studied this. In Indianapolis, that number for inpatient care is twice Medicare. That's not just Anthem WellPoint, that's all in. So we have to find better value for hospitals, for doctors, for all of us. So we're moving beyond rewarding unit cost, and we're moving beyond payment that isn't aligned with quality to that which is aligned. And we want to very much measure results. Now, this is not about one measurement or two. This is, in our instance, about 45 different measurements, and measurements that matter. Measurements that matter, from ICU staffing to what Don Berwick did when he was at IHI, saving 5 million lives, to CDC recommendations, to a whole set of real objective outcomes of care, looking at the American College of Cardiology's catheterization indicators, to look at all of the elements in terms of improved outcomes for pneumonia and heart attack and surgical care and nursing indicators. But this is what we are working with our partner hospitals to create: better health outcomes in hospitals. And I'll give you an example of what we've done in California. We were involved with what's called California Patient Safety First. We funded this with a $6 million grant and our in-kind contributions on data and analytics, working with all the hospitals. And you can see that we were able to reduce deaths by 11%, deaths from sepsis. We were able to reduce hospital-acquired infection, whether it was ventilator, pneumonia, or central line. This is how we can make a difference: improving a health outcome, saving lives, about 800 lives saved, and importantly, avoiding costs so we can reinvest in our future. Now, here's another model, how the delivery system, as it's structured, can change fundamentally. And one of these ideas is patient-centered medical homes. We've been involved in about 10 of these projects around the country. In most of these projects, it's not just Anthem or WellPoint going it alone. In Colorado, we did this with state Medicaid, and we did it with all of our peer health plans, as we did in New Hampshire. The New York results are our own, so we've done it with and without partners. And what's so dramatic about these patient-centered medical homes is that quality improves in diabetes care and heart care. So quality improves. There are less hospitalizations and emergency room visits. There's greater persistency of medication use. And in fact, in New York, we were able to show a 14.5% reduction in the cost of care while we were achieving better outcomes. That's really the goal of these models. Now, the HHS and CMS, Center for Medicare and Medicaid Innovation, CMMI, have taken this on, and just 2 weeks ago, I had the privilege of being with Secretary Sebelius and Rick Gilfillan, who leads CMMI, where they announced a public-private initiative that would test a model. It's going to be in 5 to 7 geographies. I hope Indianapolis can be one of those. But basically, it's when the private sector gets together with the delivery system and proposes a model that includes continuity of care, planned care for chronic conditions, patient and caregiver engagement, and coordination of care. And what the feds are going to do is pay about $20 per member per month to each doctor. That's about $240. And if you start doing the math, this works out between the private sector payments that we make and payments that CMS will make of a few $100,000. But what is to happen is those practices are not just to take the money to enhance their income, but to hire nurse coordinators, nurse care managers, people who will be embedded in the practice to improve care. That's a model that we hope, as I said, we can move forward with. Now, there's another model that's very much under development in the nation. In fact, CMS has actually established regulations for what are called accountable care organizations. Accountable care organizations are going to be taking financial risk. They'll have global budgeting in many instances to basically care for the continuity of medical issues for patients. So from prevention and wellness all the way to risk management and treatment of chronic illness to taking care of the most complex individuals. And this really is what I've mentioned here in this slide is a race to value-based care, because today we don't have that. As wonderful as hospitals can be for inpatient care, it's not about the continuum of care. And I'll show you some of that in a minute. So really, to get there, to win, it's about coordination of care, evidence-based care, information at the point of patient engagement, a focus on health prevention and risk reduction. This is the model that has to be created, a model that's actually emerging from the work of Aspen. So thank you. But along the way, there are a lot of concerns. When Jonathan Blum was actually in Indianapolis, and I don't know if any of you were at that meeting where he actually went on a listening meeting to talk about what they could do better, there were a lot of concerns. There were 65 complex quality measures. There were attribution, meaning how do you in Medicare determine who is the doctor for an individual patient. The hospitals, as you know, have had a velvet revolution around the nation. Over 50% of doctors in cardiology, oncology, and primary care are now salaried and acquired by hospital systems, and we'll see more of that. So that's the revolution. Well, the hospital systems historically have acquired rainmaker physicians in oncology and orthopedics and cardiology because it was to drive revenue. Now you're getting global payment in these models. How does that work? Are we going to see the delivery system come together and actually using maybe drugs that are less costly but also not as effective? Those are issues that we all have to deal with as we move this model forward. But I want to share a model that also involves what we've done on the acquisition front. There's a company called CareMore that is California-based. They're in Arizona and Nevada also, and we envision expanding this. We acquired this company that serves Medicare beneficiaries. It takes full risks, so it's called a Medicare Advantage plan, and their model of care is vastly different than anything that we have today in the country, because what they do is they take that 15% of very complexly ill individuals, those with many illnesses such as diabetes and end-stage renal disease and cancer, and they actually assign them a physician called an extensivist. That physician cares for them in the hospital, outside the hospital. That physician does it. She or he does this with an array of support structures, including nurse practitioners, with technology in terms of biometric activities. And what it starts is by inviting everyone in for a healthy start visit. That's where it starts, where risk can be assessed and care can be optimized. The specialists manage intensive chronically ill members, as I said, and there are even centers that people go to where they can exercise, where they can get physical therapy, where they can literally have foot care from podiatric physicians. So that's really the model. And when you look at what they've been able to achieve in congestive heart failure, reducing hospital readmissions in half, end-stage renal disease, reduction in hospital admissions, for diabetes, having hemoglobin A1Cs, a measure of the diabetes control, near normal. Now, not everyone can get care in these CareMore centers or in the best of physician and hospital environments, but here's how important it is to actually coordinate care. Today, if you're a Medicare beneficiary and you're hospitalized, within 30 days, 1 out of 5 of Medicare beneficiaries will be rehospitalized. So 20% rehospitalization in 30 days. What's more stunning is that half of those individuals, from the time of discharge to rehospitalization, have had no interaction with the healthcare system. They never received follow-up on their drugs. They never received follow-up visits with doctors or nurses. That's a missed handoff. So what we've done at WellPoint is just basically identified patients with the greatest opportunity for us to make a change, created discharge plans, made sure they got their medicines, followed coordination of follow-up care. So none of these are extraordinarily difficult to do, but no one was doing this. And we were able to reduce that number for our Medicare members to 14.5%. Still a long way to go, but think of that waste and inefficiency when you're just rehospitalized. Think of how that money could be used differently. Here's another example. We talked about the extraordinary advances in advanced imaging, MRI and PET scan, and those imaging advances make a difference in care. But what we've seen, and others have seen, is that that's one of the fastest growing trends, almost about 15% a year, and much of this imaging is unnecessary. It doesn't meet the standards established by professional organizations, such as the American College of Radiology. So we have looked at this. We have a company called AIM, American Imaging Management, that actually looks at high-impact, high-cost advanced imaging procedures. And all it does is guides doctors to choose the right procedure. If you're following an individual with cancer, the PET scan is probably better than the CT, but not all of them. And when we did this, our imaging trend is in the 0 to 5% range. And we also are able to look at individuals who are getting excess radiation exposure because of multiple CT scans, and we let them, and they and their doctors know that this is what's going on. Now, there's also a revolution in innovation that's occurring in care management. Today, we have thousands of nurses, and other health plans do also, that are sitting in call centers calling people. Not very personal when you get that call. So we're using webcams. With Verizon, we're experimenting with mobile-to-mobile video chat. We're even with Cisco doing high-definition TV at home for families, and our nurses have these Cisco systems called Home Presence. So we have to make care more personal. One of the most personal ways that we can advance is actually to embed health plan care managers working with doctors and practices so that these decisions are made at the point of care. Now, one of the other themes where we need to innovate is how we acquire and use medical knowledge. What I've shown on the right side of this slide is that each year there are 1 million new articles, scientific and medical articles. No one can keep up with that type of knowledge, certainly not the primary care physician on the front line. And if you look at the literally 21 million articles in Medline, so how do you manage this large amount of data? How do you influence evidence-based care? And how do you, have a capability for all of us to continue to learn? And I want to share an innovative area that we're partnering with IBM on, because what this calls for is artificial intelligence. So if you can watch the next video, you'll see some of this unfold.
And you'll remember Watson, the supercomputer turned superstar after he beat his human opponents on Jeopardy. Well, Watson is about to get down to serious business. The insurance giant WellPoint is going to start using Watson to help diagnose and treat patients. And more than 34 million of us could be affected. ABC's David Wright reports on man, medicine, and machine.
A heartbreaking work of this.
He's beaten Jeopardy's best.
What is staggering genius?
That's right. Now Watson is poised to make crucial decisions about medical care. WellPoint's announcement today marks the first time the IBM supercomputer has ever gotten a real job.
Dr. Watson has been studying for many months now, and he's gone through medical school, internship, residency.
Anyone who's ever been a patient knows that the pitfalls in our system can put people in jeopardy. Insurance companies may not pay claims. Procedures can put people in the poorhouse. And even the best doctors have been known to make mistakes. So is the obvious answer Watson? Watson can process 200 million pages of data in under 3 seconds, giving even Dr. House a run for his money.
MRI the spine. If that's clean, cut her open and biopsy the leg.
Watson might not need to order so many expensive tests, which no doubt is part of his appeal.
I would hate to see an insurance company use Watson to deny a claim.
But even on Jeopardy, Watson has made mistakes, like when the answer they were looking for was a type of loose-fitting dress.
Watson, what is chemise?
No, sorry, that is incorrect. Entrusted with life or death decisions, some worry Watson could end up becoming like Hal from 2001.
I'm sorry, Dave. I'm afraid I can't do that.
WellPoint insists that won't happen when the computer's in next year.
Really, Dr. Watson will serve as a consultant to physicians, not replacing physicians.
He may be the smartest doctor in the world, but compassion and bedside manner may be a struggle, even for a Jeopardy champion. David Wright, ABC News, Los Angeles.
What we have done is one of our test models is to actually use Watson in oncology. And the reason we thought oncology would be the area to apply Watson is because the rapid advancements in science that are occurring. We're understanding more and more about the human genome, and that whole genome sequencing will occur over the next years. It will be affordable. And also we have instances where many individuals with cancer are not getting state-of-the-art care. So that's really our first use case, and stay tuned. We'll have more to say about that. As we are today, where we are today is actually Watson has been educated on all of the cancer treatments and up-to-date information on cancer care. And let me share why this is important. It is important that we use the knowledge of what works in healthcare. And I know that later today there will be a session on effectiveness and comparative effectiveness, but I want to share a story. In fact, for me, this is a story that kind of shaped where I became sort of involved in more public policy and changed my career in healthcare, because I spent most of my life at Harvard as a basic scientist creating drugs and new treatments. But it actually is a story of breast cancer treatment in our country. And bone marrow transplantation actually entered the medical marketplace in the 1980s. There were no effectiveness studies that were done. And it wasn't just in private practice, it was academic medical centers, and about 30,000 procedures were done over a decade, extending into the late 90s, with extraordinary cost. In fact, Congress in the states enacted mandatory coverage legislation for bone marrow transplant. It really took a decade and 3 studies, 2 European, before people realized that there was no difference in survival and, in fact, a lower quality of life. What is most, I guess, shocking about all of this over that decade is that not only did many women go through very difficult treatments and spent significant time in the hospital as opposed to being with their families, but because people thought the answer was there, it delayed research and the introduction of promising other therapies. And if we look at today, now we have molecular diagnoses of certain breast cancers. Breast cancers express certain proteins, and there are highly targeted therapies for individual cancer treatment. And of course, the science showed that to be effective. So the question then is, how do we take and advance knowledge? And what you see here are 4 different treatments for prostate cancer. These are 4 different radiation treatments. I'm not even going to get into the debate right now of whether screening matters, PSA screening matters. The U.S. Preventive Services Task Force says it doesn't. Secondly, whether you should have surgery or radiation therapy. There's no evidence that one is better than another. But here are just 4 radiation modalities. And what you can see is the cost of proton beam is almost $100,000 versus the cost of more traditional radiation therapies of $20,000. We don't know which works better, but we should learn that, because that will determine how to use resources wisely. And that's what, in the Affordable Care Act, the Patient-Centered Outcomes Research Institute is intending to do. Let's look at something as ubiquitous as back pain. 9 out of 10 of us experience this. It's the #1 cause of lost productivity at work. $90 billion annually on treatment. Most back pain resolves within 6 weeks, independent of what you do. We studied almost 200,000 of our members, and we found that despite all the clinical guidelines, despite all of the processes we have in place to make sure people get evidence-based care, there were 1,000 surgeries done in the first 6 weeks. And these were surgeries when there wasn't a neurologic impairment or reason for surgery. We saw 35,000 advanced imaging procedures when the treatments, all the recommendations say one should not do that. And then we saw that care was only dependent on one thing, and that was who you went to as a doctor, not what your symptoms were. So that led us to create new models of bundling payment and educating physicians and doctors on treatment options. Because what our goal is, and what the goal of effectiveness research, is that if a procedure or a drug is superior, we must cover that. We must embrace that, and we must make that the best model of care. It'll enable patients to choose the more effective treatments. If treatments are comparable, then the patient should be involved in personalizing that treatment decision. We know in personalized medicine, we have to be sure that personalized treatment should be managed by physicians with their patients. But if a treatment is ineffective, and we have many that are, such as arthroscopic knee debridement, we need to stop doing these. There's a belief that as many as 30% of procedures done are ineffective. Now, how do we use then innovation to educate patients as I close? One way is to give patients information, and here you can see what we do at WellPoint is we give you information on the drugs you're taking, the medical services you're getting, and we also apply the best we know about clinical science. So if you're not getting the right treatment and you require a blood thinner, or that blood thinner may interact with another medication, we're telling you that. We're telling your doctor too. The member or the individual, we give information they can understand. The doctors, we give the scientific information. And we also give information on cost. Here's an example. If any of you go to Anthem Care Comparison, you can see, and this is based in Indianapolis, but it's all over the country, all the other Blues use it, the consumers can see comparison, side by side, of inpatient, outpatient procedures. There are almost 50 now. Safety, the patient experience, complications, length of stay, all of those issues for the hospitals. But in addition, we show cost and quality data. So you see quality first, outcomes first, but then cost. So here, if we were looking at, in this case, spinal fusion, you can see the cost varies by almost 2.5-fold. So we actually put not an estimator, but what our true claims cost is. And this is the transparency that people need to make informed decisions. Here's another theme. This is about emergency room care. We know our emergency rooms are full. Those of you from hospitals here, I know, again, you're at capacity, there are long waits, and not everyone should be seen there. What you see on the right side of the slide is what it costs us, not the bills, but what Anthem paid for emergency room care. Now, these are what we call the itises. They're acute conditions, but they don't need to be seen in emergency rooms, sinusitis and pharyngitis and otitis media, yet they need to be seen. And what we saw is the average cost was about $600 versus if you go to an urgent care center, it's about $50. So what did we do? Well, first, we educate people. We have brochures, letters, emails, website, telling people how to get care, when they should go to the emergency room and when they shouldn't. You can see some of that here. We also have Google Maps and smartphone applications, so you can see central Indiana, and you can see where those centers are 24 hours. So this is a way of getting people to the right delivery system for care. Here are results that non-emergency ER use decreased 20%. So that's really what we want. The quality of care was actually better in the retail clinics when we look at the outcomes of care. Here's another way that we can innovate, and that is to use the vast amount of data that health plans have. You're going to hear from Marcus Wilson later this afternoon how we can take our pharmacy, our laboratory claims, and improve public health and population health. So what we're doing with the FDA today is a national safety surveillance system. We're using our data to look at drugs after they are in the market to assess their safety. So we're working on vaccines and biologics. We worked on a H1N1 vaccine. We're looking at drugs, and we're doing many other things that actually can improve care in the domain of public health. I want to close because we've all been touched by Steve Jobs, both as we read about his life and what he brought to the consumer as we think of ourselves as how do we engage consumers in health. And this is a quote from Steve Jobs that he gave at Stanford's commencement speech in 2005. You can't connect the dots looking forward. You can only connect them looking backwards. So you have to trust the dots will somehow connect in the future. You have to trust in something, your gut, destiny, life, karma, whatever. This approach has never let me down and has made all the difference in my life. Well, I would argue that while we can't connect the dots until we look back, we must connect the dots. And I think the principles that Aspen has come forward are the dots that we need to connect, are the elements that we need to embrace to build a healthcare system that works for America, that truly will be the beacon of discovery, the beacon of quality care, the beacon of population health, and the path forward to solve the problem of our American healthcare system. Thank you so much.
Please join me in thanking Dr. Nussbaum one more time because he's really taken time to come over and set the stage for the rest of the day in innovation. And now I have the privilege of telling you we have a 15-minute break, which means you can have something more to drink, something more to eat, and I will be back again to let you know that it's time to sit down for our first panel, and it's going to be an exciting one. So enjoy your break. Thanks. Before we start our first panel, Dr. Nussbaum has been gracious enough to say he is willing to take some questions after his presentation. So we are going to start a little earlier so that we can do just that. So Dr. Nussbaum, I'm going to ask that you come up here and show some more slides.
No more slides, just questions if you have any. And
thank you. The future of fee-for-service medicine. You talked about how PPAC is forcing now 50% of the physicians now employed by hospital systems. I've asked at a recent Indiana Health Insurance Exchange conference of Preston Gee, I believe his name was, of Trinity Health, that he saw fee-for-service ending in the next 4 to 7 years toward more integrated or bundled payments systems. What your views on fee-for-service, its life, and in terms of quality outcomes and anything else you'd like to take it?
Sure. I think there are many who believe that fee-for-service medicine and unit service payment has been the sort of the fundamental flaw in American medicine. But I don't think it will end over that 4 to 5 year frame. I mean, if you think of today, Medicare represents the largest payer. It continues in fee-for-service. These demonstration projects, like the one I mentioned, is a 3-year demonstration project. So I don't think it will occur with that tempo, with that degree of acceleration, but I think it will occur. I didn't get into great detail on the patient-centered medical homes, but here's how we pay for them in the 10 or so that we're doing. We pay fee-for-service medicine, actually. That's the foundation. But on that, we build a care coordination fee, similar to what Medicare is doing at $20. And then we build a fee that is paid for higher quality and better outcomes and more effective use of medications. So when you put all that together, our goal is to continue to not grow the fee-for-service component and grow the other components. When we look at ACOs, what we're doing today is we're looking at risk adjusters. This is very technical, everyone, so I apologize a little bit. We look at risk adjusters and we build budgets. And then if you meet budgets, there's gain sharing. But I think it will be some time before there is fundamental change. I think it depends on how many people embrace ACOs. It depends on what happens with medical home. If you ask people at CMS, they believe it will still be under 25% over the next 3 years that will be reimbursed in these new models. However, we know that everything reaches a strategic, inflection point. And once you're salaried and once you're used to managing budgets, it is actually the best way of redeploying resources. You can determine, how you can use new methods of patient interaction. That it doesn't have to be a visit where you're compensated for that. It can be group visits. It can be a virtual care. So that's where I think it will happen. It will accelerate, but it will not be completely replaced. So 4 years from now, we'll see where we are in that. Thank you. Any other questions or comments? Again, thank you. And I know this day, as I looked at the panels, I'm sort of sad that I can't join you. I have to be elsewhere. But it's really illuminating, and I hope you'll all come away informing, because you're the voices of the community, and being informed. Thank you again.
And now this is the flow for the rest of the day, with the exception of lunch, which we will have another address. We are going to, I will introduce the moderator for the next panel, and it is the moderator that will introduce the panelists and basically frame the conversation and then go into a wonderfully exciting dialogue over that topic. So this next panel, Legacy of Partnership, is going to be moderated by John Katzenberger, who's an award-winning reporter and editor who left journalism to revive the Indiana Fiscal Policy Institute. And that is a membership-based not-for-profit that was formed in 1987. His experience covering business and politics in Indiana for more than 2 decades has provided the underpinning for his regular spot on a panel of Indiana Week in Review, a statewide PBS program. Aside from his professional activities, Katzenberger is also a board member on the Indianapolis Press Club Foundation and the Indiana Pro Chapter of the Society of Professional Journalists. Welcome, John. Over to you.
Well, good morning. David and Bart, if you want to just come on up and we'll get started here. I guess I'm doubling up. Thank you all for being here. Thank you for allowing me to be part of this. And I'm looking forward to hearing what David and Bart have to say, because these guys know what's happening and can share what's happening when it comes to life sciences in central Indiana. I will get to the introductions first, and then we'll get to framing the topic. But I think most of you in the room know who these gentlemen are. We'll start to my immediate right, and David Johnson, who was one half of the All Roads Scholar Senate race a few years ago. What's that?
Someone always has to bring that up.
Well, I'm happy to be the one whenever I'm with you to bring that up. So it's my pleasure, and I think it's a good piece of information for people to have. David is president and CEO of BioCrossroads, and BioCrossroads is a unique organization in that it takes a market-driven approach to collaboration in leveraging the life sciences sector in Indiana. It's, I think, a very good strategy for taking what Indiana already does in some disparate areas and putting together the power of those organizations and leveraging that on behalf of the state. They've also done a great job of raising money for capital formation to help these companies come to fruition and to grow. The $73 million Indiana Future Fund is the first evidence of that. And then the follow-on fund, the $58 million In Next Fund, and then the $6 million Indiana Seed Fund, which is invested currently in 11 promising early life sciences businesses. Not only a Rhodes Scholar, he is a graduate with honors from Harvard University, the Harvard Law School, and Oxford University. Please help me welcome David Johnson. And there's Bart Peterson, former mayor for 2 terms. And my neighbor, well, not really, because when I moved to my new house, I was shocked to learn that I live next to Bart Peterson, who works for Lilly. And I thought that was very interesting. And I guess that you and my neighbor have met in the meantime. But I think it's a small world when 2 Bart Petersons not only live in Indianapolis, but work at the same place in Indianapolis.
It's a confusing world.
That's right. In fact, he's got seniority on you, I believe.
He does.
Bart joined Eli Lilly and Company in 2009 as Senior Vice President of Corporate Affairs and Communications, member of the company's executive committee, and he received his bachelor's degree from Purdue University, part of the Purdue Mafia that populated the Bayh administration early in the 1990s, and took his law degree from the University of Michigan in 1983. As we said, he was mayor of Indianapolis for 2 terms, ending in 2007. Was president of the National League of Cities during that tenure, along with IU, Purdue, Lilly, and the CICP, which is a Central Indiana corporate partnership formed by BioCrossroads to do what we had talked about it doing earlier. Prior to joining Lilly, Bart was the managing director of Strategic Capital Partners, and he was also a fellow with the Institute of Politics at Harvard University's Kennedy School of Government, and after that was a distinguished visiting professor of public policy at Ball State University, where he remains on the board of advisors for the Bowen Institute for Public Affairs at Ball State. What's not listed here is another collaboration that I think is relevant, although not quite on point, and Bart was involved with the development, and I believe remains on the board of the Mine Trust, which is another unique organization here in Indianapolis devoted to bringing change to the way schools are thought of and operated in not just Indianapolis, but throughout the country. It's on the leading edge and is doing some great things. So please join me in welcoming Bart Peterson to the panel. A legacy of partnership, the life science industry's brackets, ongoing, thankfully, contributions to the Hoosier economy. And you could argue that this is likely the future driver of much of the Indiana economy, whether it be manufacturing in this sector, research, development, and other activities in this sector. So that's the broad category. But I guess I'd like to start with you, David, if you don't mind, just talking a little bit about why this is the case here in Indiana, and how you give me an assessment of where we stand in the arc of development of this partnership and this important part of the economy in central Indiana.
Okay, thank you, John. I appreciate that, including the part of your introduction about former political forays. When Crossroads was put together about 10 years ago, and the gentleman to my right here had a huge amount to do with that, we were put together largely as a private sector and university-driven and philanthropically driven group. And that's unusual because most healthcare, economic development, life sciences initiatives in most parts of the U.S. are publicly funded, they're publicly driven, and they generally have some sort of political agenda to them. And there was a real desire in this community for that not to be the case. And we were very fortunate to have a mayor at the time who shared that view and shared that vision. So although he was very supportive of what we were doing and really caused it to happen, it was never politicized from the very beginning. And the reason that was important was it was significant here, John, to answer your question, to get the business sector fully committed to what needed to happen over the coming decade and what is starting to happen here. This community, and really this entire state, has been a life sciences center for over 100 years, since Colonel Eli Lilly started Eli Lilly and Company in 1876, since Reverend Depew, a traveling salesman selling miracle cures and leg splints that work, found that if he stayed at Winona Lake up in Warsaw, Indiana, he could sell, and went to enough of Billy Sunday's revival meetings, he could sell more leg braces there than he could anywhere else on the road. So he stayed in Warsaw, Indiana, and set up Depew Orthopedics in 1895, and that led to Justin Zimmer coming to work for him, and the two of them hated each other, so Zimmer went off and he founded Zimmer, and a few years later, Dane Miller comes to work at Zimmer and decides that he can build a better mousetrap and founds Biomet. So and this is true. It's true of the predecessor companies of Roche Diagnostics. It's really true if you look at this entire sector, healthcare sector in Indiana for the last 150 years. It was founded by entrepreneurs, and it was founded by entrepreneurs largely for opportunistic reasons that entrepreneurs use. The problem was there weren't many people being very entrepreneurial by the turn of the century. And what we had here in this region was about 30,000 people in the central part of the state who were working in the life sciences sector. And that 30,000 is about the same number that work in the life sciences sector in San Diego, too. But in San Diego, they work in 500 small, nimble sort of biotech companies of the future. Here they worked in about 10, largely vertically integrated companies that were the real mainstays of the community, Lilly, Roche, Guidant, AgroSciences, and others that will always be the mainstays of the community. We are confident of that. But that also needed to have a much more entrepreneurial and much more networked, risk-sharing environment with all kinds of additional players coming onto the stage. The other thing that nobody could have foreseen was the significance of the healthcare sector in our life sciences sector. The job numbers that we use and that Bart talks about on his Life Sciences Minute that runs every week on the Inside Indiana Business, we are pretty orthodox in reporting life sciences jobs, and we restrict those to the traditional pharmaceutical device, diagnostic related technologies and chemicals sector. But if you started looking at healthcare, Central Indiana is one of the largest, most sophisticated healthcare markets in the United States. And having WellPoint headquartered here underscores that fact. What's happened in what some of the things that Sam was just talking about in the healthcare sector, the increasing drive to be tailored, to be personalized, to be efficient, mirrors exactly what's happening in the drug and device side of our life sciences economy. And so increasingly we've had a convergence really of our healthcare and life sciences players. An organization like BioCrossroads has really struggled to keep up with that, hopefully, and maybe even to stay 1 or 2 steps ahead to be sure that those players are continuing to talk and work together. So again, unlike most other communities trying to be in the life sciences or healthcare business, we're in that business, have been in it for a very long time, and have a tremendous pedigree of success. The question was what we were going to do for our next act, and that's really what we've been about over the last decade, trying to figure that out.
Bart, can you build off of that point and help frame this issue just a little bit further? And then I want to get back to the next act that David just made reference to.
Yes, thank you, John. And it's a real honor to be here with you and with David, without whom there would be no BioCrossroads. And it is, no one can speak better about these issues, both nationally, I would argue globally, as well as here in Indiana, than David. And he was not just present at the creation, but one of the key hands in the creation of what we then called the Central Indiana Life Sciences Initiative. Thankfully, somebody came up with a different name, and it is now BioCrossroads, and it is statewide, and it is a sense that all, I mean, it is evidence that all is right with the world, that David then a few years later, after being the driving force behind the creation of BioCrossroads, became the CEO of BioCrossroads, and today runs it. You know, sometimes dreams come true, and one of the dreams I had when we began this effort was that we would be spoken of in the same breath as San Diego and the Boston-Cambridge area as a biotech hotspot, that the life sciences industry would have the kind of reputation that would advance our cause. And reputation obviously isn't everything, but if you believe that reputation bears at least some resemblance to reality, if we were going to get a good reputation, we had to have the goods. We had to have the reality on the ground. And by having that reality, and then also having that be known across the country and even across the world, our ability to attract the kind of future investment was going to be enhanced. So when I picked up Time magazine a year or so ago and read an article, I believe it was by Bruce Katz, who's the sort of the leading urban economic academic in America today, saying that, highlighting Indianapolis as a life sciences capital, right up there with San Diego, it was that dream really coming true, that we were not only doing it, we were being recognized for it, being talked about, and that was going to help us do even more of it and advance the cause even more. Kind of building on what David said, to me it was all about the assets that we had. As I used to say, every town in America with more than 500 people has a life sciences initiative. That was true back then. I probably still is true today. They all have a life sciences initiative. But for most, it's just a pipe dream. It's aspirational because they don't really have any assets to build upon. What we had in Indianapolis were terrific assets, which David mentioned. And another, which I don't think he mentioned, which was the commitment of the Lilly Endowment to help us sort of support the creation and the operation of a new organization that would help organize these assets, bring people together, help create that critical mass out of what were a bunch of really terrific building blocks. So we started with fantastic assets and felt that those assets weren't performing for the city, for the region, for the state, as a single whole, but were rather successful in each in their own spheres. If we could bring all that together and create the to use an overused word, the synergies that came with each of those different successful organizations playing off of each other, we could have something that really made a difference and that would really start to perpetuate an industry that would advance medical science, but also create a lot of jobs and opportunity for the people of Indianapolis and the people of Indiana. And while that dream is far from completely fulfilled, we've made tremendous progress down that road, but it all started somewhere. It wasn't an accident. We may have been fortunate that we had WellPoint in Indianapolis. We may have been fortunate that we had Lilly, the North American headquarters of Roche Diagnostics, Dow AgroSciences, the second largest medical school in the United States, and of course the Lilly Endowment. We were fortunate to have all those things, but on their own, they weren't going to create BioCrossroads. That required the kind of leadership that David and many others back 10 years ago showed. So that's where it has to start. It has to start with something worth building upon, but then it has to be done the right way, and I believe the leaders of BioCrossroads have done that.
Bart, I appreciate the building upon that initial sentiment. Let's start with you, and then we'll get a little more specific, I think, with David about capital formation, because these companies that are collaborating or at least are working and pulling the oars at the same time, that's very important, undeniably. But the next generation, the next phase, the additional ideas don't go anywhere unless they get funded. And some may get funded through traditional means, through the corporate chain. But how are we doing, and what can we do better to find, build, incorporate, make funding available to these good ideas so that we can perpetuate this industry in central Indiana in particular?
Well, one of the things that I think BioCrossroads helped us all understand was the need for more venture capital in this arena in central Indiana. And I think we're all aware that venture capital, and of course that industry has changed pretty dramatically over the last 10 years, but venture capital as it was then, and even as it has evolved today, tends to be concentrated on the coasts. And inland cities have a real challenge in trying to acquire capital for entrepreneurial ventures, to take strong ideas, young, promising companies to the next level. It does require that capital, as you said, John, and it just didn't naturally flow to Indianapolis or really anywhere in the Midwest. And so the effort to create new vehicles for investment capital to be placed in support of entrepreneurial ventures in Indiana was really, I think, if we look back on it, probably the single most significant initiative of BioCrossroads. Lilly, the company that I work for now, has been a major supporter of each of the funds that have been set up by BioCrossroads. So let me just tell you why we have done that. Have we done that just to be a good corporate citizen? Well, there's always a little bit of that, but one of the things that I think is so important about the way we've advanced as a more sophisticated region in this area is recognizing we can't rely on corporate philanthropy or altruism. That will only go so far. And in fact, no matter how much of that you're able to get, if it's not focused on market-based returns, it's ultimately not going to be as disciplined and as effective as it needs to be to make a difference. So these funds began as market-based investment vehicles to attract capital. And by investing in these, Lilly was looking, to make money. In the scheme of things, it's not a huge amount of money for Lilly. But the real focus was to help generate these new companies, to help encourage the creation of new businesses and the growth of new businesses, because we believe that by creating that critical mass, a lot of startup companies, a lot of middle stage companies, a lot of big companies that we have in Indianapolis and in Indiana, what we can do is we'll create an environment in which we can attract and retain the best scientists in the world, which Lilly has always had as its top priority, the best scientists in the world, the best leaders in the world to come to this city. And it's going to make it a lot more attractive if there is a critical mass of life sciences businesses. And it's going to show people that there are opportunities. And by creating new companies, by participating in creating new companies, not doing it always ourselves, in fact, very rarely doing it ourselves, but by participating in the creation and the support of new companies, we are helping to support idea generators who are creating businesses that we might want to acquire, that we might want to in-license potential medicines from. that might be able to provide services to us in the future. And all these things have happened. This isn't just some sort of a dream. David can go into some of the details. I'll supply some of the details as well. But these things have actually happened. That was the theory, and it's actually happening in very specific instances that we can point out.
David, we talked a little bit at the beginning about the funds that have been created and the formation of those. Bart talked about participating in those funds. Where else are you getting money, and how effectively are you able to redistribute that money to help do what Bart was talking about?
Yeah, thanks, John. And Bart really did a tremendous job of setting the table on this discussion. When we started all of this, and on this topic, it is a very long time ago because the markets have changed a lot, including on some of the factors that we're going to talk about here today. When we started this, we were trying to do it to solve a very simple problem. At that time, Lilly Endowment, which, by the way, working with several other foundations here, we've had $600 or $700 million of targeted strategic philanthropy focused on life sciences and healthcare research, much of it coming from Lilly Endowment over the past decade. So in some regions where government has done that, we've been blessed with strategic philanthropy that has really moved the needle in making a lot of things happen. And right after the mapping of the human genome, in fact, Bart, I think this is probably what was the impetus for getting all of this started at a particular time, Lilly Endowment knew that mapping of the human genome was going to change science, was going to change medicine, was going to change a whole lot of things in healthcare, because we finally had the data that we needed to begin to really address disease and figure out why certain people had certain things and other people didn't, and what to do about it. And so the endowment, being the wonderful institution it is, came to the IU School of Medicine and said, you know what, we'd like to make you world-class leaders in this area. So we're going to give you, this was obviously a negotiated process, but at the end of the day, we're going to give you a significant grant that will enable you to certainly study the ethics of this. We want you to have a very strong bioethics component to really looking at the ethical implications of having this kind of knowledge and working with it. We also want you to be sure that you have the laboratories and the computing power to take advantage of it intellectually. But ultimately, we want you to go out and hire people. We want you to go out and bring the best and the brightest here to Indiana to really work in developing out these wonderful scientific capabilities. And as wonderful as that gift was, the challenge with it was finding those people to come here. Because although we had all of those wonderful assets that Bart just mentioned, if you were a world-class research scientist in genomics or proteomics research in 2002, and there weren't very many of them then, there aren't a whole lot more of them today, but there were very few then. So you were hot, you were in big demand. You weren't going to go somewhere if that environment couldn't promise you that if you came up with a really interesting, cool discovery in the laboratory, and you went to the trouble of getting it patented and working with the university to get the technology out the door, you wanted to be able to form a company and be an entrepreneur as well. That was sort of the new generation of scientists. Those people weren't coming here because the universities didn't have that ability at that time really to do a whole lot with the technology. There wasn't a lot of active licensing. There was really no one to work with that academic entrepreneur to try to figure out how to make that idea happen. But most importantly, there was no money to do anything with it. So if you came up with a really good idea, it was going to go to California or Boston or somewhere else to get developed. It was not going to happen here. And so you as the scientist would say, well, if my ideas are going there, how come I'm not there? And so to get something going here required that we become not San Diego or Boston or Silicon Valley from a capital standpoint, because if you take a look at where capital is distributed, private equity and venture capital in this country, it's ridiculously concentrated on the coast, and it will always be so to the extent that those markets remain intact, and that's an interesting question too. But although we were not going to compete with that, what we had to have here was enough of a presence that if you had an idea, you could take the first steps to commercialize it. And if you were in the venture capital business, Indiana was on the map, so you might come out and say, what could we do to try to help get that funded? And that's really was the idea behind the whole venture capital strategy that Lilly led the way really to help us form. WellPoint was involved in this as well. Our corporate community and philanthropic community and foundation community really stepped up to put these funds on the table around a market-driven, return-driven initiative. And those funds have worked well. They have actually given a pretty strong return to their investors. The $73 million, for example, that went into the Indiana Future Fund has brought another $275 million of outside venture capital here. In the capital business, you want to be a net importer of money, and we have certainly become that. And we've seen 36 companies take life and grow, and only really a couple of them not continue in the struggle forward, which is a pretty darn good batting average to have. And that's 36 companies or 34 companies that just wouldn't have been here without this initiative. And we've seen some other companies like Endocyte up in West Lafayette, very promising cancer company that was able to take venture capital at a critical time and go public earlier this year. Very few companies have gone public in the markets today. That's our second largest pharmaceutical company in the state, actually, after Eli Lilly and Company. But at the same time, the world has continued to change around us. The good news for us is we have become full players and participants in the global markets. The bad news is those markets are global. They are very competitive, and the access to funding and capital gets harder and harder and harder for companies and ideas all the time. So other forms of partnerships are becoming increasingly important, and we look to our partners, IU Health. You're going to hear from Dan Evans here today. They have a very interesting internal venture capital model where they invest in companies, and we often invest alongside them. Lilly has some very interesting opportunities that they're promoting through Lilly Ventures and through some other structures to try to put more money into promising startup companies. In addition to that, we are looking at our healthcare system, for example, here as it's coming up with interesting medical technologies to find ways that perhaps they can incubate companies, so take some of the expense out of getting them formed, and we can help with some initial capital coming in. Trying to leverage some of the federal stimulus dollars that have been out there in the last few years to try to drive more early funding toward companies has become important. Finding angel investors to step forward, which we didn't have here in this sector 10 years ago. We have a very strong network of those now. This game for money, it is sort of like being a political candidate, I guess, because you are constantly looking in every possible source, and then you're going back and looking again. As the science gets harder, the technology gets tougher, and the stakes get higher. And also, on the other theme of this conference here today, as efficiency becomes valued in the healthcare market, as ACOs really start to work, as hospitals want to be sure that they are purchasing technology that is the best possible and the most effective possible and the most efficient possible, that will change what people will finance and develop in the marketplace. And we need to be very sure that the companies that we're investing in early on are ultimately going to have market success on down the road. So for us, being part of the broader community, not only providing funding for it, but understanding the ultimate market by working with folks like Lilly and WellPoint and the Cook Group down in Bloomington and others, is invaluable for us as we try to continue to get it right in putting some of these new companies on the map.
Okay, Bart, so we've talked about the companies that have been involved, the companies that have been formed, kind of the raw material, if you will. We talked about the money, which allows is the flux to allow these activities to occur. But one of the pieces that we haven't talked about is the actual brain power. We've talked a little bit, in other answers about, the people, the human assets. But what about Indiana has made this formula work as it has when it comes to, the brain power, whether it's higher education or in industry or whatever it may be?
Well, I think that's a great question, because at the end of the day, that is what matters most. And these other things wouldn't be possible without that. And so to have the extraordinary public and private universities that we have in Indiana has made an enormous difference. And these are universities that have a lot of talent in the areas that fuel the life sciences as well. So we've been fortunate there. To have a company like Lilly, and I was saying this long before I worked for Lilly, so I'm not just giving a commercial here, but to have an organization, a company like Lilly that has such depth of talent in the scientific arena is a huge asset. To have the medical school that we have, but as David pointed out, that's a medical school that has really very significantly grown and improved over the last decade, in part because of this effort, but really because of the overall concentration of the leadership at Indiana University and the IU Medical School to make it a world-class medical school. So these things all come together. And I also think, I think back to my days as mayor. I remember Sidney Terrell, who was the CEO of Lilly at the time I took over as mayor, said to me, you mayors and governors, you tend to think of economic development in terms of incentives. So you give us tax abatement, or you give us some other, credits, tax credits for hiring people. At the end of the day, we're all in the private business world. We'll take those things if you offer them to us. But the really important thing, the most significant thing that you could do as mayor to help us would be to make Indianapolis an even more attractive place, to make it a great city that people want to live in. We're on that track. Let's keep that going and make sure that that becomes a primary focus. That really is more important to us at the end of the day than tax incentives and other breaks that you give us to grow employment and to grow investment here. And so what we've really worked on is not just sort of looking at the life sciences effort in isolation, but recognizing that our success in the life sciences is going to be due to talented people. And talented people can live anywhere they want. And as we often note around here, we don't have a lot of mountains. Crown Hill is a couple hundred feet high. But usually it's a street curb that constitutes a hill in Indianapolis. Flat has to be beautiful to you. So we don't have that. We don't have seashores, but we have an incredible community and the kind of attractive place that people inevitably say, gosh, if they come here for the first time, what a fantastic surprise this city is. So we need to make sure that it's no longer a surprise, but it stays fantastic. But the point here is that you have to look at this holistically. It's all about the talent first and foremost. They have to have exciting opportunities, as David was talking about. That's what's going to attract them here. But they also have to have a place that they want to live. And it has to be a place that's good for people who are our age. It has to be a place that's good for people who are young. And that's been a real focus of our efforts as well. So we have a lot going for us between the universities, the companies, the quality of life in the city. But again, it's about putting all of those things together and packaging them in a way that's attractive to people that ultimately makes a difference.
David, what does Indiana need to do better in developing its brain power and its human resources in this particular realm?
Well, in part, John, it comes to having a better understanding of what kind of brain power we need, at least in this sector. And that comes in turn with getting better data. For example, we issued a report earlier this year, which is actually on our website. It summarizes progress in the life sciences sector. It's called Indiana's Life Sciences Industry 2002 to 2010. That is my only commercial today. But it's worth looking at because it's the first time that anyone's actually drawn some data together about this sector and really begins to answer the question of who works in it. And one of the things we found out was that although we think of our life sciences sector here as being predominantly pharmaceutically based, there are a lot of people in the biotech and pharmaceutical business, but of our 50,000 souls that work in this sector, 40% of them are in medical devices. And the people that work in the medical device business, by and large, have a very different academic and skill profile from those who work in the pharmaceutical business. It's important to understand it. In many cases, a high school degree or an associate's degree in the traditional orthopedics or cardiovascular device manufacturing is the right degree, is a terminal degree. Whereas at companies like Lilly, you're just getting started when you have your BA. And interestingly enough, although just a couple of quick statistics, the average Hoosier wage is about $39,000 right now. The average Hoosier life sciences wage, all these sectors in, is about $82,000. So not a mystery that you want to have more of these jobs. And interestingly enough, even in the medical device sector, where the levels of attainment, again, are often high school or associate's degree, the average wages in that sector are between $60,000 and $65,000, which, again, compared to $39,100, is quite an impressive differential. So for us, the question is not only how do we do we drive more talent and more skill and more able people to companies like Lilly, but also, frankly, how can we be sure that we are getting our more basic educational programs fully aligned to some of the other sectors here, including the medical device sector that's going to count. The other real quick problem in this area is all these technologies are changing. So if you're in the medical device business today, you're primarily an engineer. Tomorrow you may need to be a biologist if you have a device that is actually going to deliver a drug or involve regenerative tissue. And so the skill sets involved in training people, even at basic levels, are undoubtedly going to change going forward.
John, I just wanted to add something. I was thinking about the fact that in our next panel we're going to have Steve Witz, who runs the Regenstrief Center for Healthcare Engineering at Purdue. And we often, at least coming from central Indiana, where pharmaceuticals are more dominant than the device industry, although Cook is very close by and Warsaw is not that far away, we tend not to think first and foremost of engineering when we think of healthcare. But the reality is, if you're able to take your strengths, and Purdue is renowned across the world as a leading engineering school, you're able to take that strength in engineering and pair it with not just the medical device industry, but with a broad range of systemic issues in healthcare delivery that are susceptible to engineering analysis and engineering-based solutions. You're going to hear about that from Steve. Then you're really taking your strengths and making the most of them, and I think Archie is a wonderful example of that.
Well, we've talked a little bit about leverage as well, and you know, it's a matter of recognizing and then acting upon, and we've been acting upon this now for a full decade, officially through SILC and BioCrossroads. So, crystal ball this a little bit. How do you see it, given the vast changes we've seen in the last 10 years? How do you see it going in the next 5 to 10?
We are, BioCrossroads is currently working with a team at Battelle and in a series of intensive conversations with both our research universities, our healthcare systems here, and also our corporate players to begin to try to answer that very question. What are the areas what are the hottest areas for us to be really thinking about and collaborating in and trying to build new opportunities going forward? There's going to be continuing huge opportunities in personalized medicine, which means many different things to many different participants. There's going to be enormous opportunities in orthopedics, although that sector is going to change a lot over the next decade as we work through the baby boomer generation, I guess, but also as regenerative medicine does come more into play. The importance of data, whether it's called healthcare information technology or whether it's called clinical information or whether it's a migration between the two, is only going to accelerate and is going to become the common currency of everything we're talking about. And there's going to need to be a tighter and tighter working relationship between the academic bench, and we have a very generous portion of it right here, and the corporate research bench. And there are obviously challenges in that. There are different cultures, there are conflict of interest issues, there are all kinds of things that get in the way of bringing those parties together. But I think Bart would agree with this. If you are sitting on top of the pharmaceutical innovation world as the Eli Lilly and Company does today, it's a company that's completely committed to a novel, first and best-in-class innovation strategy. That is its strategy going forward in the future, as I understand it. And if you're committed to that, you are committed to having just an exorbitant number of really smart people who are in the pipeline of your company forever. And you can't hire all of them. And the harder the science gets, the more you need those relationships to be networked across many different providers of innovation and discovery and development. Lilly understands that well, which is what's made them such a wonderful player for us here, because their strategy is inherently an innovative, partnering, new company creation strategy. So it's great to be in a community with a pharmaceutical company for whom that is their bread and butter. But for that to work, it's going to require the universities, Purdue, Notre Dame, IU School of Medicine, and others, to continuously ask, how can we partner with this company, but also with other pharmaceutical companies across the United States to continue to make our research even more translational, more targeted, more about what's going on in that broader sector. And there's a lot of issues that are a part of that discussion that we're going to have to work through. The other challenge is going to be funding, because the science is just plain getting harder, and the regulatory side of this gets tougher every day. And the traditional model of taking an idea, building a little company around it, feeding and watering it, and trying to throw more and more venture money and hoping that someday Pinocchio grows up to be a boy, I just don't think that's going to happen in a number of cases going forward without a lot of other players, strategic investors, university incubators, and a whole bunch of other people being involved in the process to really bring the best and most promising ideas forward. Bart works with a guy, John Lechleiter, who is the perfect person to articulate many of these challenges because he's a scientist. He's a deal guy. He really understands sort of how the world of private equity and venture works and is very comfortable in it. But he's also a supremely academically gifted person. And from his vantage point, he really understands and articulates well the challenges of innovation, not only for a company like Lilly, but for a community like this one, which is based on the success of innovation going forward. So there's not a real easy crystal ball on that, John, except to say that along the lines of what Bart said earlier, we've got all the pieces here, all the players here, and they kind of like each other in this community, which is also really helpful. We do not have people sort of going off and forming different initiatives and trying to kind of go off and do it on their own. People really are willing to come together in projects like this one we're doing with Battelle right now, have open and honest conversations and figure it out. So I'm confident about the outcome, even though I can't tell you what the shape of it's going to look like.
What do you think, Bart?
You know, I have a front row seat here, and I have not seen a single fist fight break out in this room. People really do like each other in this industry in Indiana.
Yeah, but you noted that in Warsaw, when people didn't like each other, it made more companies.
It's different in Warsaw. It's different in Warsaw.
Maybe that's the formula. Yeah, we've got to get a little more antagonistic. I'm going to throw a bit of a downer note in here, if I might, which is that all this that has been built here in Indiana for the benefit of our state and for the benefit of our nation, and I believe for the benefit of the world, really is at risk as public policy decision makers contemplate what the shape of healthcare is going to be going forward. There can be bad decisions made, and those bad decisions can really bring all of this crashing down. And I don't want to sound overly alarmist, but I truly believe, pardon me, that there is a lot at risk right now. And you know, I think Sam articulated a lot of these points exceedingly well. First of all, technological innovation is not our enemy. And we have to create a political and policy environment that promotes innovation as opposed to one that discourages innovation. And it's real tempting to promote one that discourages innovation. To look at the medical device industry, to look at the biopharmaceutical industry, to look at a number of other industries as simply vehicles through arbitrary cost-cutting measures or price-cutting measures, to be able to fund a system that is chock full of bad incentives. A fee-for-service industry that really can't sustain itself as needs grow and costs grow unless it just starts whacking costs everywhere and whacking reimbursement everywhere. And if that's the vehicle that we take forward, and if that's the model that we embrace, we will kill the innovation engine that is supporting Indiana's really emergence as a worldwide player in the life sciences arena. So policy decisions, you know, we as Judge, to give you one example, the pharmaceutical industry, the biopharmaceutical industry is facing the potential of dramatic cuts in Medicare Part D funding. Now, we as a company, that's being considered as part of deficit reduction. We're fighting against that very hard, but we as a company invest over 20% of our gross revenues, in R&D. In fact, Lilly is the #1 company. There are only about 10, depending on how you count them, 10 to 20 true multinational biopharmaceutical companies left in the world, and 10 of the traditional ones, and Lilly is one of those 10. Of those 10, of those 20, we invest the highest percentage of our gross revenues in R&D. We are the most innovation-focused company, one could argue, from that data. But our peers are also committing a very substantial amount of their money to R&D as well. And if we essentially say to this industry, we don't value innovation, if we say that to the device industry, or we say that to others who are coming up with creative ways to solve unmet medical needs, then I think we not only are going to impair the progress we've made in healthcare, but we're going to have a dramatic impact on our national economy as well. You saw some of Sam's numbers on the percentage of new drugs of all kinds that are developed in the United States, 2/3 of all new drugs over the last 10 years. But over 80% of all biopharma research takes place, of all biotech research takes place in the United States. We lead the world in this. We need to make sure our policymakers don't help bring that to a grinding halt with some of the decisions that they make over the next few months and over the next few years. But let me end on a positive note. Okay. And I think about this in, again, reflecting on Sam's presentation, and he is one of the great thought leaders on healthcare, I believe, in the United States. And what we have an opportunity to do is really evolve to an industry and a set of industries that make up the life sciences cluster in Indiana to really focus on patients. And if we are able to evolve a business model that is truly focused on health outcomes instead of just inputs, and that includes companies like Lilly that right now are compensated only for the number of pills we sell, only for the number of vials that we sell. If we can be compensated in a new model for the degree to which we help people get better, we can partner with WellPoint and others in helping really develop a healthcare system nationally that is focused on health outcomes rather than inputs. And I think we are uniquely positioned here in Indiana because of WellPoint, because of all the other companies, because of Lilly, to really help lead the way in that regard. And we've got some of the great thought leaders in America who are working in that direction. So I'm very positive about the future, but I did want to say that that future is not guaranteed to us. Just because we have done well up to now doesn't mean that we cannot, as a country, make bad decisions that really put us in a bad position.
Before we finish with an answer from David elaborating on this, I want to remind you that we'll have a session for questions here in just a few minutes. So be thinking about what you'd like to ask these two, and you'll have that opportunity in just a couple of minutes. So, David?
Yeah, I just want to add a note of a really urgent endorsement to what Bart just said. One of the things that we as BioCrossroads pride ourselves on is that we are not publicly funded. We've raised about $262 million to date from corporate investment and philanthropy. And there have been public sector investments in some of our companies through the pension funds, but we have proudly been independent of public sector funding. So we don't spend a lot of time going over to the General Assembly asking for state assistance. There's a number of things that we don't do. And so I'm often asked, well, what is the role of government in this process? And there's an answer for that at the state level, which is a little different from the answer at the federal level. But increasingly, the answer to that question is don't screw it up. And there's an awful lot of things that government can do to get in the way of making progress happen here. On the one hand, the fact that we might in fact have a healthcare system that puts value on efficiency and sort of sets the bar for people to move toward an efficient target for the development of delivery of healthcare in a system that will more or less cover everybody, that's very promising. If people will really do that and set that up and then let the market go to work at trying to provide innovation to it. But if we are continuing to do that by having uncertain policies across federal agencies, starting with the FDA, but a number of others as well, and if we try to pay for some of these things on the backs of innovation, then that innovation will never happen. I was sitting at a conference actually in Warsaw on the orthopedic device industry, where we had Biomet, DePuy, Zimmer, and Paragon and Symmetry, who are the big suppliers of that sector, on a panel the very morning that Congress decided to finish up the healthcare reform bill by adding in the medical device tax. And for those of you who don't know, what they found as they were getting toward the end of that process was there was about a $40 billion shortfall. And unlike some of the other sectors, unlike the healthcare sector and the pharmaceutical sector, the device sector really hadn't been a part of those discussions, hadn't come to the table to talk about what the package might look like. And so the news was coming around that morning, and I was watching all the government affairs people from these companies just all over the place trying to figure out what they were going to do about it, that the solution to the funding gap in that bill was to stick it to the device companies and basically have them shoulder the $40 billion in a tax that is very difficult to levy on device companies because they sell to hospitals, so they're not a direct governmental contractor. So the idea was that the tax would go to the bottom line of the companies as a direct tax on income. And somebody asked, and that's indeed what did pass, and someone asked the panel for an immediate reaction. And one of our best spokespeople in that sector is the guy named Toby Buck, who runs Paragon, which is one of the premier suppliers in the orthopedics business. And he looked up and he goes, "You know, folks, we just were the last pickle in the barrel when they plucked us out and they stuck us with this." And that was his, that was the down note for that sector, which again is sort of the future of so much of the state and that part of the state, in being burdened with something like that could really, it will affect jobs, it will affect innovation, it will drive a lot of opportunity off the shores of the United States. Now, mercifully, we have for the first time here next week a field hearing that's being put together through Congressman Todd Young's office. Neil Pickett's daughter is very involved in putting that together, in fact. I see him back there. And we're going to have 5 of the Indiana delegation and several members of Congress from other states to come and have a field hearing and talk about the impact of the medical device tax on states like Indiana and Minnesota. It's very timely to do that. We need to be better and stronger as a community. The work that Roger does on the Hoosiers for Health program, there are a number of people who are really starting to think about ways to get government more in people's view here. But we've got to be sure the policymakers at the state and the federal level are informed about the consequences of some of the things they're doing and some of the ways they're thinking of paying for things, and what the impact of that is going to be on an industry whose future is dependent, and I would submit a state whose future is dependent on innovation.
Wow. I got about 14 questions, but I think it's important to give you the opportunity to ask questions. So let's open this up, and if you have a question, please ask it now.
Greg Wilson from the IU School of Medicine. Is the educational system in Indiana at all levels ready to meet the challenges of the innovation that we've discussed this morning?
Well, I think we're a bit of a strange state, right? We have one of the most powerful higher education systems, public higher education systems in the country, and of course the U.S. leads the world in higher education. So in that sense, once you get past 12 in the K through 16 and beyond continuum, we're pretty darn good. We're very well set and very well focused in this area, as I said earlier. The K through 12 challenges that we face as a state are also very, very well known, not just in the heart of our urban areas, but there are challenges across the state of Indiana. We could, I don't know how many more hours we have, but we could talk about educational improvement. But yeah, I don't think there's any question that the K through 12 system has got to get better. There are a lot of efforts to help make that happen. John mentioned the Mind Trust. That's a cutting edge effort to approach education reform from a different way than it's been approached in this state in the past. And there's a consensus, I think, around the need for change, and a consensus around doing some pretty dramatic things. And we're starting to see positive things happen. So I'm not wholly discouraged about it at all. I see actually a future of improvement, but we have a long way to go in the K through 12 area.
David?
Agreed. We have a higher education system here that we're actually a net exporter of talent, which is sometimes a good thing and sometimes not. But we certainly have a system that's well equipped for the challenges of science, technology, engineering and mathematics. That's a little more problematic on the K through 12 level, although again, we have worked, and Lilly Foundation's been involved in this, Lilly Endowment's been involved in it, Purdue and 11 other institutions around the state have helped us to put together a K through 12 STEM initiative to try to get kids more literate in science. And part of a big initiative like that is, where do you start? So you start by training high school algebra teachers to teach algebra more effectively to students, to get them interested in high school algebra, because as it turns out, if you miss that one, if as a student, if you miss that level of educational attainment in high school, you're unlikely to end up in one of these companies or in these opportunities. So are we there yet? Absolutely not. But have hundreds of teachers been trained and thousands of students been benefited by that program after 5 years? Yeah, it's a start, and we hope to start seeing it in some better test scores with a number of those kids.
Other questions?
Thanks. You mentioned the strong higher ed system, and there's no doubt about that. But would you comment, both of you, on your perspective regarding tech transfer from the academy, from IU and Purdue, and what you've seen changed over the last few years, and is that on a good track, and can it be on a better track? Because that strikes me also as very critical. It's a cultural issue as well as a capital issue in terms of encouraging folks to pursue their innovations further than just the academic bench, as you mentioned.
Neil, thanks. It has certainly gotten much stronger here. Indiana University has really entered the fray full bore on tech transfer and has done a marvelous job in the last few years, in particular, developing facilities, the policies, some pretty reasonable licensing policies, which a lot of universities struggle to do. Purdue actually had a head start in this area. It really started back in the 80s and the 90s, and they have built well on that start and have continued to put some really outstanding companies into the field, and they continue to incubate them. The University of Notre Dame has become a player. They weren't at all 10 years ago, and have decided that a part of their key mission is really digging down in certain areas of biology and engineering and being sure that they too are having reasonable tech transfer policies going forward. That said, university business relationships are challenging, and the cultural differences between or among, but between academia and industry are profound. And the more time that we spend in them BioCrossroads as an organization, the more we respect those barriers and differences. People work on different incentives. They have different ideas of what matters. And universities, as originators of technology, also have different approaches to it, oftentimes, than corporate partners do. So we need to do more of it. We need to do it better, and we need to keep the conversation pretty open. What I mentioned to you earlier, I think that those challenges will get somewhat easier to overcome, because the only way that really strong research is going to get funded is increasingly by having a component of it that's sponsored by industry. And in turn, the only way that industry is going to get the innovation that it needs is by having those relationships more and more with academia. It's going to go from a nice to have to got to have in terms of that relationship.
Bart?
Yeah, I don't really have anything to add. I think David said it very well. I think this is, was a big focus of BioCrossroads from the very beginning, and there's a lot of success here.
We have time for just one more question, if someone has one.
Could you elaborate on the obstacle that conflict of interest regulations and scrutiny imposes on the kinds of collaborations that are essential to innovation going forward?
That's a pretty sizable topic. Let me just try to take one bite out of it, and to say that in my industry, the biopharmaceutical industry, there is increasing scrutiny being applied to the relationships between physicians and pharmaceutical companies as they do their research. Pardon me. It's absolute. Pharmaceutical companies and biotech companies cannot do their work without collaboration with physicians. and cannot do their work without collaboration with academia. And there is a movement that I think is wholly appropriate. In fact, Lilly has been on the front edge of it, was the very first to disclose our payments to physicians here in the United States. Now it is part of the Affordable Care Act, the so-called sunshine provisions of the Affordable Care Act that make this kind of transparency mandatory. But Lilly did it voluntarily before it became mandatory, and it's a lot of work, but it's something we believe in. When you tell people what's going on, when you're transparent about things, sometimes people learn about stuff that they didn't know about before, and they think it's actually a worse situation. Well, I think it's far different than that. I think it's a much better situation because we know exactly what these payments are being made for, and it gives us an opportunity to explain exactly why it's essential. We literally could not develop medicines that serve people without working closely with the people who actually deal with the patients, who actually are in the business of curing patients. So this is a hot topic in our industry right now. I think it's appropriate that it be a hot topic. I'm proud of Lilly for leading the way in transparency, but I think we have a long way to go in terms of resolving some of the criticism out there that some of these relationships are inappropriate. Are there bad apples? Are there inappropriate relationships? Of course that does happen. But the vast majority of these relationships are about serving patients better and about developing medicines that actually work. And so we're very proud of those relationships. But this is the hot topic in the biopharmaceutical industry right now.
And I would just add, it already is the hot topic in the medical technology business. Most devices, whether they're orthopedic, cardiovascular, urological, are developed by clinicians. They're developed by doctors and surgeons in practice who see something that could be done better and end up either forming a company or forming a relationship with a larger company that's already in that business, or both. And the question is what is the integrity of the research? What is the integrity of the prescriptive care? And what is the integrity of the relationship? Some people say those questions are so complicated we can't answer them. We have to be able to answer them, because I would submit, and Bill Cook used to say this far more eloquently, you're not in this business unless you've got a conflict. I mean, somewhere along the line, if you're not already sort of on both sides of it and understand how innovation really works and translates into human practice, if you haven't been on both sides of that question, then your innovation isn't very good. And unfortunately, where you get that knowledge of both sides is inherently putting you in a conflict situation. So there have to be better rules of the road and more predictable ones to address it.
Well, thank you for your attention for our panel, and I think it's pretty evident that the legacy of partnership in Indiana's life sciences industry is in good hands with these two and many others of you who are in the room. So please join me in thanking them for their time today.
Thank you.
Well, thank you to all three of you. It was just a really riveting conversation, and there were no fistfights, and that's clear that this is a great place to be. I have the privilege of telling you we have a 10-minute break, and largely because we want to have a longer break after the second panel so that we can get our lunch and then have enough time to listen to the remarks at lunch. So 10 minutes, and I'll be back to let you know that it's time to sit down again and listen up.
We really have a terrific group here for our second panel, which is entitled Healthcare Reform's Impact on the Delivery Care System, Opportunities and Challenges. And this will really get right to the heart of some of the issues that we've touched on a little bit already this morning. And we have a broad range of perspectives, both Indiana and national, here on our panel. So I'm grateful to each and every one of you for participating. And I'm going to ask a kind of a broad question at the beginning and allow each of our panelists to sort of use that to give some, hopefully address the question itself, but also a chance to sort of frame their perspective on these issues as well. So let me introduce our panelists. Immediately to my right, your left, is Jack Harris, who's the Vice President of Medical Affairs, the Medical Director for Lilly USA, the largest national affiliate of Eli Lilly and Company. So one of our leading physicians within Eli Lilly and Company. Jack received his medical degree from the University of Mississippi, and he came for a residency to Indiana University and joined Lilly in 1989 as a clinical research physician. He's held a number of positions and, as I said, is currently Vice President responsible for the U.S. Medical Division within Lilly USA. Jack, thank you very much for being part of our conversation this morning. Next is Bob Goldberg, who's the Vice President and the co-founder of the Center for Medicine in the Public Interest, a very influential organization in this space that we're going to be talking about here today. It's a nonprofit promoting medical innovation and personalized medicine. Over the last 20 years, he's conducted and sponsored research on the impact of restrictions to new drugs, or the impact that restrictions to new drugs have on medical spending and on health. Bob was previously director of the Manhattan Institute's Center for Medical Progress and chairman of its 21st Century FDA Task Force. Bob, thank you very much for being here. Marcus Wilson is president of HealthCore, a wholly owned subsidiary of WellPoint, focused on outcomes research. Dr. Wilson received his degree in biochemistry from Virginia Tech and his PharmD degree from the Medical College of Virginia, and he's a member of the FDA Mini Sentinel Program's Project Operations Council, Brookings Active Safety Surveillance Council, and the Observational Medical Outcomes Partnership Executive Board, which gives you a little sense of where his interests and expertise lie. And then finally, Steve Witz, who I mentioned earlier, who is the director of the Regan Strieff Center for Healthcare Engineering and the St. Vincent Health Chair of Healthcare Engineering at Purdue University. Steve joined the Regan Strieff Center as its founding director back in 2006, and is a little bit more on Archie, or the Regan Strieff Center for Healthcare Engineering. It's an interdisciplinary research center applying systems science to improve healthcare delivery with major research projects emphasizing care coordination to improve population health. And I know Steve's going to go into a little bit more detail on the specific work that Archie is doing. So with that, again, thanks to all of you for being here. Let me begin by asking all of you to consider the following question. What do you see as the barriers? No, I'm sorry. I shouldn't have 17 different pieces of paper in front of me, so I don't want to start with the barriers question just yet. Let me start with this. We face the challenge now of implementing the Affordable Care Act, maybe, but we're all proceeding as if the Affordable Care Act is the law of the land for now until further notice, and making improvements to the delivery of health care in the United States. So I want to ask each of you what you see as the opportunities ahead of us to make meaningful changes in the way that health care is delivered, to reach improved outcomes for patients, and to build a more sustainable health care model. What we've kind of all agreed is the foundation of improving health care delivery. Better quality outcomes and an affordable and sustainable system for the long run. So, Jack, would you like to begin?
Sure. Thanks, Bart, and good morning. It's a great question. I'm kind of smiling inside because one of the things that happens when you work at Lilly is that somehow, magically, all of the things that you did before you got to Lilly kind of become unimportant. I'm a physician. Lilly has about 400 physicians that are employed worldwide, but there's a joke among the physician community that once you come into Lilly, you're no longer have the perspective of a healthcare professional. You have medical expertise, and you have scientific expertise, and you have that kind of stuff, and you care about patients. But when the marketing people come ask you, they never ask you, what would a physician think about this? You know, what would you know? You're a Lilly employee, you're not a physician. And the reason I bring that up is because I think industry sometimes gets left out of the equation on, you know, what opportunities are out there, you know, to improve healthcare. We have a lot of very talented and passionate people. I mentioned the physicians we have. We have so many nurses and PharmDs and other scientists and even the folks that work on our business side and not in the research and development have this great passion about patients and helping patients live longer and healthier, lot more active lives. But there's a, you know, you kind of touched on the barrier word, and I won't get into the barriers yet. I'm ready for that question. You know, I think our acceptance as part of the solution is a real challenge for us. The data that we generate is scrutinized, I think, more heavily than data that might come out of academia. We talked about conflict of interest earlier and such. But just from someone who works in the company and has been there for almost 23 years, it's amazing the passion and the clarity that we have about what we do and what we're trying to accomplish. One of the things I think that industry can bring to the table to help improve the healthcare system, and I don't want, you know, this is the P word, and it's kind of, you know, scary to some people, but it's process. We are a very process-driven organization in the industry. You have to be when you're dealing with as much stuff as we deal with, and there's just a lot to do. And there are a lot of ideas, and there's a lot of urgency to get things done, and you have to bring some process to that. And sometimes when I look at the healthcare world, you know, I see a lack of process. And it doesn't mean, you know, rigid guidelines that say you cannot deviate from this path. It's more about how do you take a whole bunch of stuff that people are trying to get done with an end in mind that is a positive end and make that happen efficiently, cost effectively, resource wisely, whatever. So we have expertise and we have process perspective on doing things, and again, in order to deal with complex situations, I think process is very important. One of our challenges that we are faced with on a daily basis that I think is an important piece that we need to bring to the healthcare environment is meaningful research. And I say that's a challenge, not so much today, but when I first joined, I can remember, again, back in the 1980s, that, you know, the research we did, while it was good quality research, I'm not sure it was answering the right questions. You had a drug out there and you had another drug that basically did the same thing, and how do we show that this drug does the same thing and somehow has a slight advantage? You know, those might have been important questions for a scientist to ask about their particular pet project, but were they things that the physician treating a patient or the payer paying for that treatment or the government approving that treatment really wanted to know about that drug and that particular, you know, product or that new molecular entity? So we are obliged today to perform meaningful research that does help, you know, pragmatic trials, whatever you want to call it, that does help to bring a solution to the table in dealing with the scourges that we're trying to treat, and things like Alzheimer's and cancer and diabetes and all these you know, significant medical challenges that are out there. And then the last point I'll make, and I know you want to get to certainly the other panelists and not use too much time with this, but is around personalized medicine. This is the Captain Kirk, in my opinion, the no man has gone before kind of opportunity that's out there for the treatment of patients. Sidney Terrell, who was, of course, our previous CEO, would say, you know, it's time for us to develop the right drug for the right patient at the right time at the right cost. And that was kind of the rallying cry behind, let's get on this personal medicine mission and make this happen. The technology is there, the need is there, the ability to say that this drug, you know, is almost guaranteed effectiveness and almost guaranteed a toxicity profile that is extremely acceptable to a patient, and it has a cost that is extremely reasonable. You know, that's the kind of guarantee I think Americans want and people want these days in this sort of a world of I want it now, but it's the right thing to do. So from a physician's perspective, you know, being able to pull a magic bullet out and say this will fix your problem I think is a a great advance. So personalized medicine is something that we're very interested in.
Great. Thank you, Jack. Bob?
You want me to talk about opportunities?
Either way. Opportunities, challenges, your choice.
Yeah. Well, I think the opportunities emerge as we see that most of what has been proposed doesn't get implemented. So the catastrophic care provision of the Act, only a few thousand people have signed up. They granted thousands and thousands of waivers because otherwise people couldn't afford coverage. The Class Act has been essentially put on ice. So those main components have been scuttled. We also find out now that counting Social Security earnings of certain people will add 3 million people to Medicaid. And I just found out yesterday that if you decide to pay the fine and not get coverage, you can still present yourself to a federal health center or an emergency room and get all the care you want. There's no penalty for that. So for those people who don't want to buy health care, there's your loophole. So there's a lot of problems, but I think the opportunity that emerges from that, Bart, is that it creates a contrast for what I would call the American miracle, of which Lilly has been a part. And that is that advances in health, which have increased life expectancy, delayed when we get sick, how we get sick, the severity of illness, have increased the length of retirement over the last century 5-fold, increased the number of people that can live to retirement 7-fold, and the amount of leisure time that we can have even as we're working 4-fold. And that in the future, this progress is going to continue to accelerate. We've become so rich and so able to produce so much, not only of necessities and luxuries because of medical innovation, that it's actually led to the elimination of disparities in income and life expectancy around the world. And the point of that now, the important point with regard to those advances is that health care is a superior good. Consumption of health care should not be suppressed artificially by the government. Just because we have a crazy way of paying for the delivery of care. If we were going to start from scratch, we would not pay for health care that way. We'd pay for it the way that we're doing it in the Healthy Indiana plan, for example, with health savings accounts, where people have an incentive to align with their doctors to do what's best for them to stay healthy. Actually, as an aside, we're doing a video of Healthy Indiana, and we interviewed some of the people on the plan. What I found fascinating was that people use the plan not only to, they use it to get healthy so they can work, but also to save for the future, for their future healthcare needs and to stay healthy. That kind of system should be expanded, and it dovetails nicely with the future of personalized medicine. Instead, what we have is a series of cost containment efforts using comparative effectiveness in one-size-fits-all mechanisms. And I'm just going to roll off a couple of examples because they're in such stark contrast to the vision that Dr. Nussbaum laid out earlier of using data to generate clinical decision tools that allow you to do things right the first time. And as we all know, we all have the money to do things right, the time and money to do things right the second time, don't we? That's where most of the cost in healthcare is, doing it right the third or fourth time, not the first, instead of doing it the first time. But you look at what happened in the application of the ALLHAT study, which was designed to figure out what was the best drug for reducing heart mortality from high blood pressure. It actually, the application of that evidence clinical CER study actually harmed African Americans. The U.S. Preventive Services Task Force has not adopted C-reactive protein, which is a good marker for heart disease and women's health. The failure to adopt PSA and HPV testing in an era when women are no longer presenting with HPV, except if they're really symptomatic as a result of taking the vaccine, is absurd. And what's happening as a result, and we're doing some research shows something very interesting, which is as a result of the reduction of chronic illness in expectant mothers, the reduction in stress in utero is reducing the incidence of chronic illness in subsequent generations. And we're going to see that, the results of that translated into longer life expectancy and reduction of chronic illness in the next generation. And if we reduce the onset of chronic disease, of the major diseases, hypertension, diabetes, heart disease, and cancer by 5 years, we can cut the rate of increase in Medicare spending substantially. But we're going in the wrong direction. We're imposing, we did a study, and I'll finish with this, that comparative effectiveness research, the way it's being practiced now, will reduce the rate of the amount of investment in R&D by $32 billion over the next 10 years. It'll cost us 81 million life years as a nation and $4 trillion in the social value of health. And I think that as we move forward with the implementation, if it's not overturned in the courts, of the Affordable Care Act, we will see the differences between what we can do to make and create a sustainable healthcare system and what's going on. So I look forward to what other people have to say, since I've said all I have to.
A lot of rich veins to mine there, so thank you, Bob. All right, Marcus?
On that note, from a person who actually does comparative effectiveness research, so there's, in my 23 years of being a part of the healthcare system, and I'll give a little bit of history of that in a minute, but in those 23 years, there's one fundamental truth that I've come to, and I really can't find a different answer to this anyway, and that is that of all the relationships that exist in healthcare, the one that's most important is that relationship between the physician and the patient. And if we think about, if we really truly understand that dynamic and what goes on there, and those of you who are part of that relationship on either side of it, but speaking specifically the physician side of that, as a clinical pharmacist supporting those, is all the good and bad decisions happen within that dynamic. Now, I'm not talking necessarily about the things that are really important and incumbent upon the patient themselves in terms of being healthy and following those regimens, but the one that has the most influence, I think, over that is that relationship. And so everything that we do in terms of policy, in terms of programs, in terms of education, in terms of innovation, in some way or another really needs to consider that impact and do everything it can to improve that. And the things that make it worse, including our current reimbursement model, need to be reconsidered and thought about and considered whether or not we really need to do them. And so when I started out my career, I started out as I'm a clinical pharmacist, and I was embedded in a group practice for 7 years. And there's 3 things I did within that group practice. One, because the group practice was owned by a Blue Cross Blue Shield plan in Delaware, I ran the committee that decided what drugs went on and didn't go on that closed formulary for that broader population, which included many of those patients in that group practice. So that's one of the things that myself and my team did. The other that we did is we started and managed the clinical trial program for those physicians there in that practice, as well as other practices in the States. And then the third thing we did is we did a tremendous amount of education, both in terms of the physician and the patient in those settings. And the relevance to what we're talking about today is that I learned more than I ever needed to know about what's good and bad about our healthcare system within those 7 years, and realized how screwed up the system really is. And so I'll take 2 components of that because they're very relevant to the discussion today, and that is that if we think about one dynamic of this, and that is that if we think about the information that's available, the research that's out there on a given product, device, policy, procedure, then the amount of information that is actually out there versus what we really need to understand is roughly 50% in that. And what I mean by that is if you think about a pharmaceutical as an example, the clinical trial developed the process of developing a drug through a clinical trial program over time, the exposure to different populations increases. And so we learn a little bit more in each stage of development of these products about how the product works or doesn't work, how it's safe and not safe in certain populations. And then we get to a point where it's approved by the FDA, and if the product's fortunate enough to survive that long, and it comes out into the marketplace. And then the tremendous work that's done by the pharmaceutical industry to continue to develop evidence on that continues that growth and that body of evidence even post-approval. The challenge we run into is this, and we faced it head on, both on the P&T committee as well as in working with those physicians on decision support, is that exposure or utilization of the products far outstrips that cone of evidence, if you would. And what I mean by that is it's not really off-label indications. I mean, that's part of it, but it's really looking at the types of patients who get the drugs now versus those that were studied and the conditions upon which they got them. So I'm thinking about different age groups that weren't historically exposed during the clinical trials that now get it, because the physicians can write for what they want, right? And by and large. And so, with all the good intentions, they're exposing patients to those products. And that's not necessarily in itself a bad thing. It's only when we don't evaluate what happens that we sort of run into a problem. So there's different age groups, there's race and ethnicities, which clearly change how drugs behave in our bodies. We look at different comorbid conditions, severity of diseases, concomitant drugs, and varying levels of compliance. And those things have an enormous impact on what outcomes are achieved with whatever intervention we're considering. So that's one dynamic. We know that there's much less known than what we need to know to make those decisions, and we dealt with that day in and day out in that practice and month over month as we were trying to make the best decisions we could as to what products to put on that formulary. So we're looking at both population and individual level. So that was one aspect of this that I learned very early on that was a big challenge for us. And the second one was really this, and that is that if we look at the amount of time that's really needed, especially for those patients that are complex or catastrophic, that physician really needs to really truly process the volume of information they need to make the best series of decisions at that point of care. The reality is for those most complex patients, there's hours of time needed to really prep, take on that patient in that setting, and then follow up with them effectively. And the reality is they have 13 minutes. Under the current reimbursement model we have today, it severely limits the amount of time they can dedicate toward that patient at that point of time, and those decisions and a lot of the waste and errors in the system come from the lack of time they have to spend doing that. So there's two things that are sort of beginning to happen with this, and I think what we have to realize is that when we talk about comparative effectiveness, there's many different things that kind of fall into that consideration, and we also have to realize that the early adopters and sort of the trendsetters and how to do this work came from the pharmaceutical industry. They were the first to really drive into that space, saying we need to understand what's going on in that real-world setting. We truly need to understand and make sure we can communicate that effectively. And it's going to a point now to where many of the companies are beginning to try to innovate all the way back, not just demonstrate how well the products work, but actually looking at innovation with real-world outcomes in mind, that broader side of that cone, if you would, so that they can come to the market with products that are not only approvable, but reimbursable, that have great value, that can be demonstrated clearly for the community, and we can actually then get much closer to individualized therapy. So if we look at sort of the current trends, and I'll end with this today, because I think it could be good fodder for discussion on this. There's two different dynamics that I think that are evolving that will help us in this regard, or not. Actually, could set us back to Bob's comments on this, and that is that health information technology is becoming more and more prolific around the country. We're getting a lot of electronic healthcare data that's becoming increasingly available, and there's a tremendous amount of initiatives out there that are looking to aggregate those data. For better or for worse, and I fall on both sides of that in many cases, depending on how it's done. So that's one part of it. So a lot of electronic healthcare data that has the potential to be used to help generate some of that insight. The other is we're seeing a lot of emphasis on payment innovation, accountable care organizations, patient-centered medical homes. A lot of things are looking to try to widen out the bottom of that cone, if you would, give the physician the incentive and the time to work and spend that time with that individual patient so that they can work not only to make the decisions, but to work with the patient to make sure those decisions are understood and there's a good partnership that is continued to develop with them. The challenge we're going to run into is that bottom part of that, with the payment innovation, is predicated upon being able to truly measure outcomes. The only way we can measure outcomes and make an outcomes-based system is for the first part of that to evolve effectively. In other words, the use of electronic healthcare data to accurately assess outcomes. And the reality is we're not there yet. We're just beginning to learn how to use those electronic healthcare data to generate medical evidence. And a lot of the initiatives that are out there are sort of ahead of their curve. They're out above ahead of their skis on this and looking at all-payer claims databases and these other initiatives that are looking to aggregate data and then conduct research on them. The reality is we don't know how to do that yet. The methods are still evolving. And for those of us that have been doing it for about 15 years, and our part of the company has been doing it for 15 years on a very large database with our parent company as well as other Blue plans. We have about 44 million lives we work with day in and day out on these data. And the learning curve is very steep in learning how to apply methods to generate that evidence. And I think there's a lot we have to do to get that right, and then that can ultimately power a very effective payment innovation environment for us as a company, as a country. So I'll end with that.
Great. Thank you, Marcus. Steve?
Well, thank you. I am optimistic about the potential for healthcare reform, and I am because I think we're finally at a point where we've reached that burning platform moment. I think that there's a broad consensus that the system doesn't work the way we want it to, and I think there is also a consensus that it is financially unsustainable. If we try to capitalize on this time, I think we need to follow some of the precepts that have been used in policy development or efforts to address grand social challenges of different types. Both of those efforts share common characteristics that include clarifying social needs and issues, articulating proposed solutions, and creating transparency in the evaluation of piloted solutions. And so the opportunities that I see at this point in time are really based on those 3 points. And I think whenever possible, health reform is going to have to be reduced to the lowest, most local level possible. That may be local communities, it may be regions, or it may be states. I think in my reading of the health reform legislation, there are a number of opportunities that are not being adequately discussed and debated. In preparation for today, I looked at the legislation and what's being reported about its implementation since March 23rd of 2010, and I was surprised to find that 28 initiatives are reported to have been launched in that 19-month period of time. And when I looked at the list of initiatives, I'm a little bit embarrassed to say I didn't recognize many of them. And as I read the definitions of each of those 28 initiatives, I found myself agreeing with some and disagreeing with others, and concluding that it's pretty difficult to say I either agree with health reform legislation or I disagree. So I think in reducing the discussion to communities, what we're going to find is there are different definitions of what societal or community healthcare needs are. And I think that that is to be expected. We have different components of our society, different society makeups in different parts of the country. Because of that, we're likely to see different solutions being of interest for evaluation, either because the needs differ or the basic resources of communities differ, such as urban versus rural areas. I think in the health reform legislation, there is a good deal of emphasis upon trying to create local pilots and to learn from those pilots. And unlike some of the previous suggested health legislation, I think there's much more of a grassroots opportunity in our present situation that we should take advantage of. And in doing so, I think we'll find opportunities. Finally, I think one of the things we're also going to have to come to grips with is that there are not likely to be a large number of best practices identified. I think for a number of years we've existed with the idea that through pilots we'll identify best practices that become panacea and can be generalized across many different communities. And I don't believe that's the case. So we're not only going to need to carefully evaluate each pilot in terms of its outcome and its impact, but we're also going to have to include in that evaluation a determination of when practices that have been determined to be effective in one application area can be generalized to different communities. And so I think another area of opportunity that is in the healthcare reform legislation that has to be aggressively sought is this idea of creating very careful evaluations so that from evaluation we get feedback and we can proceed through a process of continued improvement.
Great, thank you, Steve. I want to ask each of you a quick follow-up question, a different one for each of you, and then we want to open it up to questions from the audience. Steve, you make a powerful point about being able to develop different solutions in different places. Inherently, it would seem that's in conflict with a system that wants to become more efficient by homogenizing everything, and at least a payment system that is not geared to different answers for different cities, towns, states, parts of the country. How do you think that tension can be resolved, if it can be? How do we feed back this notion of pilots at local levels into a system that doesn't really want to look at things differently?
Well, I think it has to be done sequentially. When I think of policy being developed for health reimbursement, I think of programs like Medicare where there need to be national standards and consistency. I don't think that should be the lead challenge for us. I think we first really need to understand what works and then go back and look at reimbursement. I also don't think that Medicare and Medicaid may necessarily be the right areas for trial. Most providers today are not able to cover their costs in providing services to individuals insured by either program. And so it may not be a very ripe opportunity to look for trial. Alternatively, on a local level, there may be a much better opportunity to work with commercial insurance and the growing number of self-insured employers to trial different types of models that may provide gain-sharing opportunities to learn from those before reimbursement policy is really tried to be set.
Great, thank you. Marcus, you talked about health information technology as essential to an outcome-based system. What do you think some of the barriers are to being able, aside from the technical barriers, being able to manage that data in an effective way and really draw out of it the evidence that allows us to make better decisions? What are some of the other hurdles that you think we have to get over if health information, electronic health information is really going to be able to become a meaningful part of evidence-based medicine?
So, yeah, so the technical side of that is big. So to just make, to trying to look at it beyond that, get around the issues of being able to understand the data that comes out of it is which in and of itself is a big challenge. I think a lot of it is around understanding how to use it once it comes out. I mean, the gentleman to my left here, I've read some of his work, and there is a lot of concern, not just, there's a broad concern around comparative effectiveness, which often is done using these types of data. And there's two different parts of it. One of it is you want to do the research right to make sure you are conducting it in that environment and not overreaching the real capabilities of the data when you generate the evidence, but also then how does the provider or the decision maker, whoever the target might be, whether that's on a population or individual level, how do they actually understand how to use that information and really get it to go from sort of population-based research to individualized decision making. So I think there's still a lot for us to learn about how to apply research once it's generated, especially looking at comparative effectiveness. We still don't know necessarily how to apply that information, and I think there's still concern by many that and while we've had some really good successes in some areas, there's also been setback in that. So I think we've got to be careful in using the CER and using it effectively from that perspective. So I think HIT has a great promise in helping facilitate that. But I also have to make sure that we can get that information back in the hands of the decision maker, and I think health information technology plays an important role in that. But I think we have to be very careful, realizing that today, in today's world, health information technology has only gotten to the point where it can really, truly just dump a bunch of additional information in the hands of a physician, as an example. We haven't really gotten really good at supporting decision-making at that point, helping to parse through that information. So we run the risk of just dumping additional information there and still not having them, now they're having less time to process it and make meaningful decisions from it. So I think that's a big part of that as well.
Great, thanks, Bob. If you could take off on that a little bit, as Marcus mentioned, your work in the area of how we can misuse comparative effectiveness research, and you brought that up in your initial remarks. How can we approach this subject, this very sensitive subject, in a way where we don't sort of go to the least common denominator, which is just use the therapy that costs the least, but really effectively use evidence for better decision-making that produces the kinds of outcomes that we're looking for, which is improved quality and a more sustainable system?
Well, CMPI is doing just that with the Scripps Institute and Eric Topol. The first thing, of course, is that we have to, as Eric has said, shut down the comparative effectiveness research conglomerate that is being funded right now, because it's not supporting the kind of clinical decision, the kind of evidence that would allow the development of predictive tools in the clinical setting, as Marcus said, when you have 13 minutes to make a decision about dosing and treatment. The last thing you want is to have Alan Garber and his cronies come up with some retrospective analysis of, metformin versus these other drugs is more cost effective. What we want to know is, there's a genetic test on the market, by the way, that will allow you to know which of your patients are in that 25% of the population that don't respond well to metformin. Why isn't that built into a clinical decision support tool? Why isn't the government supporting that instead of this recent crap? That looked at the comparison between bare stents and drug-eluting stents in aging population. We know that. What we want to know is which patients should get what kind of drug on that stent. Eric is already doing that. Why isn't that developed into a decision support tool? Because comparative effectiveness research is used to suppress and reduce the rate of innovation. Now, I'm sorry, it may not be politically correct to say it, but we need to fund those kinds of things rather than the kind of stuff that someone like me could do in my sleep. And trust me, you don't want to see me in my sleep. It's not a pretty sight.
Do you hold out hope we can get there?
I certainly do. I think that the stuff that Marcus is doing and what Well pointed to, there's so many robust activities. I'm very, very optimistic in that respect. But we have this 800-pound gorilla, which is now interfering with the next revolution in healthcare. And let me just make one other point, which is, healthcare is a leading industry, just as electricity and manufacturing was at the turn of the 20th century. It is what other people are consuming. That's why companies like Lilly are going to China, because what people are consuming now and what they have more disposable income for is healthcare. Why do we like health? Because it allows us to live longer and healthier lives. So the investment in personalized medicine is essential to our continued growth and competitiveness in the world economy. And I don't know for the life of me why we're not doing more in that space, especially since we have so much ability and so much potential to do that.
Let's let Jack answer that question. Jack, I know that personalized medicine is something you feel very passionately about. It started off as a dream many years ago, became overnight a fait accompli in the minds of many people way before the science had caught up with the dream. But progress is being made pretty dramatically. Why don't you talk about that a little bit?
Sure. I look at the Lilly portfolio, and I would assume this would mirror the portfolios of other major pharma companies. With 70 drugs in development or so, it is an expectation of the scientists that bring those products to the portfolio that each has a genomic strategy attached to it. Now, whether or not that's going to be a successful strategy remains to be seen, right? You're not going to win on every front. In fact, most of those drugs will never see the light of day when it comes to market opportunity. But that's just the nature of the beast. However, the effort is there to drive into the development plans of those products, the identification of targets, of biomarkers, of things that can be measured to try and better determine whether or not this drug is going to be effective in that individual, not the carpet bombing approach that was, kind of the traditional drug development, study large populations, find an efficacy signal, and then throw it out there and let the doctors figure it out, and what drugs work and what drugs don't. I mean, that was the way it was done, and I'm not going to criticize that in the sense that it was wrong, because it wasn't. It's provided longer lives for people and better quality lives and such, but we can do better. Now, I think some of the issues that are around being able to be successful in the personalized medicine space, probably the biggest one is, the funding for the projects and the studies and the development of the science it's going to take to make that a reality. Somebody's got to pay for that. And then on the other end of that, there needs to be, the risk-reward sort of mechanism that if you do produce a product that has a very personalized package to it and has the data to support it, that you ought to be able to be, reimbursed for it at the appropriate level. So one other thing, Bart, I'll mention is that I get concerned about, and it's kind of on the barrier side as well, are regulatory challenges. The FDA, has its job to do, of course, and it was created for the safety of products in America. But I get concerned about pendulum swings, and that how much more effort by the FDA is now focused on patient safety. No drug is completely safe. And the last thing we ever want to do as a company is put a drug out on the market that's going to hurt people. That's just completely counter to everything we believe in. However, we all know that those things happen. And there is no perfect product that's there. And sometimes regulatory commitments, post-marketing regulatory commitments, surveillance studies, more studies, these studies, if you want this approved, you must agree to do these things, can be incredibly expensive and can also be unnecessary at times and deter companies from pursuing that sort of development strategy and investing in those kinds of things. So there's a real bright future for personalized medicine. It's not going to happen tomorrow as far as, everything for everybody, but it is the future, and I'm optimistic about it. We just have to be careful that things don't get in the way of the success.
Let me just make another point about that. Everyone remembers the Chilean mine workers. And I found it very interesting that when the way the Chilean mine workers were ultimately rescued was that they basically asked everybody in the world to come up with any technology, anything they could do to help facilitate that rescue. And they did under budget and a lot faster than they expect. They brought people in from the United States with new drills and new fiber optics and so on from Japan. You compare that to the Deepwater Horizon cleanup of the Gulf, which was held up for months because of regulatory barriers, and the fact that they had to coordinate with the, with the Coast Guard and the Navy and EPA and wildlife and all. We now live in an era where the spread of ideas and information is happening at rapid, at light speed. People bought 4 million iPhones in the last couple of days. I mean, and we have a regulatory system which has been amplified in this current bill that tries to centralize the aggregation of information and ideas. And I think we need, as Steve pointed out, to try to adapt to the way that technology and ideas do emerge and are shared.
Great point.
Just one point. I actually want to go think a little bit about the what I think is one of the greatest risks that we face right now, and I think it's specifically around new evidence generation and comparative effectiveness and so forth. The concept of comparative effectiveness, first of all, I really like that, but in my mind, comparative effectiveness has to be done right in order for it, and I think we're still learning what right is. So I said that earlier, but here's the biggest risk that I think that we need to make sure is on our radar, and that is that to go to an earlier comment that I made around us still learning how to use electronic healthcare data to generate evidence, we have to realize that any electronic healthcare data, we always thought claims data was going to be the dirtiest data we ever worked with until we started working with EMR data, and we realized just how much worse that is. So then putting them together is a tremendous task. So the biggest risk that we have is that there is a monumental wave right now going across the country. I just talking to Sam on his way out about California as an example, and that is building these big aggregated databases. And the problem you run in when you start aggregating claims databases, as an example, and EMRs are many-fold worse, but let's just stay with claims data. When you start aggregating them, you're removing them further from the source of the source systems that they came off of. And you got to remember that claims data were generated to pay claims. They come off those systems that are paying claims, not to do evidence development, not to do comparative effectiveness. And so while they have a great potential for being able to generate new insight, the risk is that sort of misinterpreting it. Each of those data systems, we have thousands of benefit designs just in WellPoint, thousands. In each one of those benefit designs and different contracting methodologies between institutions, if you really don't think about that when you're analyzing the data and adjust your confounding for the non-apparent confounding factors that are in there, then you're going to be, it's a very high risk that you're going to misinterpret what comes out on the other end of it. Yet we've got in every state just about a movement, if not already done, where you've got these big claims databases. And they can be okay if you're using for descriptive analyses to look for hot spots and kind of guide where you want to kind of dig in and understand better with better types of research, then that's fine. But the reality is most of them are being built predicated upon a comparative effectiveness research as being one of the common goals of using that database to do that work. And that's when we start running into problems, because we're going to have very well-intentioned, bright researchers jumping into the databases, doing analysis, and having no choice but to interpret it at face value.
Using propensity scores to...
And propensity scores can be useful, but they're only good unless you can know what compounding factors to adjust into that. And that's the part we're trying to make. Without knowing what the confounders are, you can't adjust your models for that. And that's the scary part about this. And so I think that's a big risk, and I think that's where we are on the same page. I really do think without comparative effectiveness and getting it right, we're not going to solve some of these issues. But we've got to do it right, or we're going to make the issues worse.
Yeah, one of the things that we've been doing is trying to do really homegrown data sets. I've been working with, you probably know Susan Horn, who's
started a lot of this.
Yeah, started a lot of this. And basically taking patient-level data, using the baseline of how sick people are, and now because things can be computed electronically, can adjust for over 250 variables to see what interventions and what treatment steps matter, and also what treatment steps work for which types of patients. And that kind of homegrown approach does overcome some of those problems. But having said that, Susan just completed a chronic pain study with Weill Cornell, Sloan, and New York Presbyterian. In integrating those data about pain was a real Herculean task, because there were all these EMR-based things. But if the government is going to do something, those are the kinds of issues that should be addressed. And really, more specifically, what are the clinical needs of the physicians, and how does it help facilitate the treatment decisions in an individualized way?
Yeah, I really like what you said, Marcus, about the importance of the doctor-patient relationship and how that is, that is just crucial to the effective delivery of health care. And I think that's where the art of medicine gets practiced. And not only if you start to diminish the ability of the doctor to practice his or her art, are you going to diminish the health care, but you're going to drive people away from the profession. And that's one thing that I'd be very concerned about having the right people in the healthcare system administering healthcare.
Well, this is clearly a conversation that we need to continue and in fact really elevate as we move forward. I think it's critical to being in a position where we can really talk about what good healthcare outcomes are about going forward. I think we all can agree on that, and I think some of the complexity of it has really come out in this conversation. So thank you all. I might just add, since Steve is sitting here, that a leader in, first of all, the development of EMR databases, and then common languages to be used to standardize the utilization of these databases, that the leading work in the world was really done right here by the sister organization of Steve's, the Regenstrief Institute at Indiana University. So another strong Indianapolis connection to the future of healthcare. With that, I want to open it up to questions from our audience. So please, we've got microphones. Just raise your hand and you'll get a microphone momentarily.
Hi, I'm Peggy Welch, and I serve as a legislator and have looked at legislation dealing with the whole claims database stuff, and have had some pushback, obviously, and there are concerns. Indiana has not really moved forward, at least through legislation, to try and collect that information. Other states have, especially in the Northeast. Are there lessons that we could learn from what they've done right or what they've not done right, that we could do a better job in the state of Indiana in being able to collect that, to provide for good comparison and also good data to help us to move forward?
I think the answer is certainly yes. There are lessons. So I want to make one comment. I'm not really against the concept of an all-payer claims database as a general rule. I just think it's ahead of its time in a lot of ways, and I worry about how it's being used. One, how you construct it, but also how you use it. I think the lessons learned are more in what things you can use it for today and what things you have to wait and be disciplined on using it for in the future. And I think that's, more than anything, I think that's key. So making sure that our expectations of putting this thing together aren't beyond what it can deliver today. And I think, so if the justification for the expense and the energy and the political will needed to put one of those together, if it's based upon sort of what realistic expectations are, then I think, and I think you'd have to work that through, then I think that's key. I sit on the APCD committee. I just got put on it by the governor in Delaware, or asked to sit on it in Delaware. So I'm helping them work through some of those issues and trying to make sure that they're thinking about the same way. The same for New York State, who has similar ambitions, and they're building one which will be the biggest in the country when it's done. And so I spend a lot of time trying to make sure that they think realistically what it's going to be used for, and how best to use it, and what things not to use it for yet, I guess. And so I think I would tap into a lot of that expertise. Patrick Miller's out a lot speaking from the state of New Hampshire, someone I know fairly well, at least I've learned to know him well through the Mini Sentinel program with FDA. So I think that's really the big key in trying to make sure that our expectations are realistic. And if you don't have enough to justify doing it, don't do it yet. Wait until we evolve further and then do it.
I'd offer two lessons. One is they did something. And I think there's a great deal of merit in doing something. The second is most of the states that have been leaders in these areas have not made the assumption that by putting a data set together and analyzing it, they're going to find the solution. The outcome is they've learned, and they're better prepared to adjust to the ongoing dynamics of the situation. And sometimes that lesson has taken an extended period of time. If we really have a burning platform moment ahead of us, I think all of us need to really put concerted effort into starting on that learning curve. And I don't think you can do it in any other way than rolling up your sleeves and becoming active in it.
Thank you. Who wants to tackle chips?
I would say yes. I think Indiana is a beta site to prove that. You have 90% of your public employees on health savings accounts. The analysis that we've done of the Healthy Indiana plan, comparing the people that have set up HSA, the power accounts versus those that haven't, have shown a willingness and an interest in using, shopping around, using information, not only about what doctors charge, but how well they perform, and much more emphasis on prevention. And I think that we always miss in the discussion about healthcare reform the role of personal responsibility for one's health. When we always talk about the fact that so much of health risk is behavioral, well, we don't have incentives to act responsibly in many cases. What we've seen with Healthy Indiana is that people that, and I've had these debates over the 20 years, and it always boils down to, and no one says it, poor people are too stupid to make healthy choices. Well, I never bought that for a reason. I was poor. I may be stupid for other reasons, but not because I was poor. You can make healthy choices if you're given the opportunity and incentives to do so. I think with these kinds of tools, it just allows you to take a step further, and the ability to go in and say, you know what, this medicine is for you. You really don't want to take these other medicines despite what you heard on TV because you're going to have a bad side effect. That's a very valuable piece of information that people will take, especially if it's your money.
So I like the concept's a great concept, so just to follow up on that. But here's the thing that medical chip has to make sure it contains, or at least you know what's missing on it. I think you have to think if it's got there, not everyone has the MRs, and yet, and so in fact, in some parts of the country, the penetration is very low. So I think we need to make sure that if we include an individual's information on a chip, if you would, that it's fairly complete. Because if you've got their information from the hospital, but you don't know what happens on either side of that, then you're fairly blind. And if you assume you have everything, but yet you've got a couple of specialists that were treating this patient, that information is now not included, then I think we'd have to make sure that we address those gaps. But in theory, if you look at, make the assumption of complete information and complete interoperability of that between systems, so that when you plug it in one place, it's translated accurately to the other, then the concepts are as a powerful concept.
I think this is a commercial opportunity for a enterprising entrepreneur because the information's there. And it's just sort of like what the iPhone does. It takes technology that was already there and put it into a form that I'm obsessed with, frankly. So that's really the key with these kinds of tools, is to make it cool and useful and convenient as part of the overall flow of life. That's why, for example, there's a program in New York for kids who are at risk for Hep C. It's text messaging to each other about avoiding unhealthy behaviors or making sure that they take their medication on a regular basis. And if they take their medication on a regular basis, guess what? They get entered into a raffle for a hip-hop concert or something like that. I mean, these are, and all that information is then stored to improve the next iteration of the prevention program. Again, it's organic, it's geared to what people want and do, and you can layer in the genomic and clinical data as part of it. And once we start thinking in those terms, I think personalized medicine is really going to take off.
Yeah, we didn't speak much about patient education, but that's obviously a very important thing. I think people really want information. The scary thing is that many of them are getting bad information when you just jump on the internet and get it.
I wrote a book about it.
Yeah, and but patients who do want to take control of their health care and be smart about it are very hungry for the right kind of information. In fact, one of the reasons I stopped practicing medicine a number of years ago was because I didn't have time, back to the 13 minutes, it wasn't quite that bad in 1989, but it was getting there, to try to educate my patients. And it was very frustrating to me. I mean, being a Southerner, I like to meet people, sit and have a long chat and talk like that. Well, that kind of medicine works fine in small-town Mississippi, but it didn't work in Indianapolis, and it wouldn't work in today's society in a large city. And I just, that's where I want to live, so I just couldn't do it. But I know that the patients wanted that information, and the more they understood about their disease, the more they could make effective choices, or the proper choices, in effectively treating their own disease.
We have time for one more question. Steve, do you want to finish up on that one?
I was just going to observe that it would seem that that solution really needs to be looked at in the context of what problem you're trying to solve. And if it makes sense, given that problem, it probably is a good idea to pursue. In pursuing it, I think it's also important to look at the entire system of care to determine whether or not that solution fits. So some of the things that have been mentioned are, do providers have the opportunity to read and write to that chip so that there is concurrent information? Another thing that's very important is I think we've overlooked the need to include the patient and the patient's family in that communication process. Coming from an institution that prides itself with engineering, one of our initial challenges was to come up with highly accurate passive implantable sensors. Let's always record and get the very latest data. What we missed is when a patient is required to enter their data, they're actually giving us more rich information. And we learned a lot more by the patients that didn't enter data than those who did. And we started to get indices of patient engagement and find different ways to treat them. So in general, I believe more information is better. I guess the caution with any of these types of approaches is to try to look at it relative to the problem that's being addressed. Does the investment in the solution warrant the benefits of resolving it in this manner? And then systematically, can we really support this type of innovation in the current form of healthcare delivery?
Thanks. Do we have one more question? Yes, back in the back, Neil.
This has been a very thoughtful discussion. I want to thank all the panelists. My question kind of somewhat jives toward part of the discussion of the last question and comments from the panelists, and that has to do with, and I know there's no simple answer to this, but I'd like to hear at least some of the panelists comment on the issue of communication of comparative effectiveness findings and the complexity, and not just direct CER, but the whole question of protocols, and you look at this with the prostate cancer findings and the breast cancer findings a few months ago and how politicized those became, how hard it is to explain some of this information, and then also how hard it is to or maybe you think it should become part of the political process. Maybe you think that's appropriate, but is it appropriate, and if so, why, and if not, how do you keep it out of that process?
Well, it's politicized because it now triggers coverage decisions, and going to what Mark has said, the quality of the information that's being used is lousy. The breast cancer, the breast screening decision didn't take into account variations in the aggressiveness of a tumor progression in minorities. The same thing with PSA screenings. The HPV recommendation ignored the fact that many minority women do not do a Pap screening because it's invasive. So HPV sensitivity and specificity is the best thing you've got. And it ignored the fact that in an era when many women are protected against HPV, you want to do the HPV is much better than the Pap smear in terms of identifying people at risk. I mean, the things, the lack of nuance and sophistication is a reflection of the quality of information. Let me just make one other point along those lines, that the reason that we